All right, so a very good evening, everyone. Yes, so I hope I'm audible and visible to you properly. Just give me a quick thumbs up if I'm audible and as well as visible. All right, so now in the today's session, I'll be revising quickly the nephrology and the connective tissue disorders. And if time permits, I will also take up the discussion related to, right? So that will be the plan for today. And the notes of yesterday's session, the PDF has been sent on to my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So I hope everyone was able to download that particular PDF. Okay, right. So even the today's session, immediately after the completion of the session, the PDF with annotations I'll be sending to you on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Okay, right. Yes, so good evening everyone, and let us start with the today's session now. So today the first important session will be the nephrology. Followed by that I'll do connective tissue disorders, and followed by that we will discuss the pulmonology. All right. Yeah. Yes, Sesha Gopalan, right? Definitely, I'll plan to complete all the topics and as well as even the other lectures as well before your FMGE exam. And yes, so those students who are unable to find my Telegram channel, so you can text me on my WhatsApp number. So this is my WhatsApp number. Okay. So you can text me on my WhatsApp number, right? So I'll send you the Telegram channel link. Okay, so don't worry, you just text me on my WhatsApp number. So definitely I'll send you my Telegram channel link. Okay, yes, Narendra Kumar, yes, Sharfaraz Khan, I will do gastro also. All the topics I'll finish, don't worry, in crisp manner I will finish all the topics. Okay, so having said that, let us start with the today's session. So the today's session, the first, what did I tell you? That is the nephrology. Okay, right. So you see the first important question. Investigations in a patient of oliguria revealed urine osmolality of 800 milliosmoles per kg, urine sodium of 10 millimoles per liter, blood urea nitrogen to the creatinine ratio 20:1. So what do you think is the most likely diagnosis in this patient? Pre-renal acute renal failure, acute tubular necrosis, acute cortical necrosis, urinary tract infection. Right. Yes, anyone want to make a quick attempt of this question? Then followed by that, we'll be discussing this important topic now, that is acute kidney injury. Okay, so I'll be discussing this important topic now, acute kidney injury. Yes, right. So this is how the questions can come. So you should be able to differentiate pre-renal from the intrinsic renal and as well as the post-renal. So let us start the discussion. So we'll discuss and again come back to this question, so not to worry about it all. So first is the acute kidney injury. You should know the definition of the acute kidney injury. So whenever you are defining acute kidney injury, we take two parameters into consideration. So हम दो parameters लेते हैं. वो दो parameters क्या होगा? एक serum creatinine, दूसरा होगा urine output. So serum creatinine बढ़ जाना और urine output कम होना. So the serum creatinine should be elevated and the urine output should be reduced. And how much is that elevation of the serum creatinine? कितना बढ़ना है? So it should be more than or equal to 0.3 milligrams per deciliter within 48 hours. Okay, 0.3 milligrams per deciliter within 48 hours, there should be increase in the serum creatinine. And at the same time, what did I tell you? Urine output क्या होना? Urine output कम हो जाना. So कितना कम हो जाना? How much should be the urine volume? So if you take the urine volume, it should be reduced to less than 0.5 ml per kg per hour for more than 6 hours. So these are the two important points related to the definition. Or even some books give the rise in creatinine of more than or equal to 1.5 times the baseline within the prior 7 days. So ये दो चीज याद रखना, एक होगा सीरम क्रिएटिनिन बढ़ जाएगा, कितना बढ़ जाएगा, मोर देन और इक्वल टू 0.3 मिलीग्राम्स पर डेसीलीटर विद इन 48 आवर्स, एंड दूसरा होगा यूरिन वॉल्यूम कम हो जाएगा, कितना कम हो जाएगा, देन 0.5 ml per kg per hour for nearly around 6 hours. ठीक है, बट अगर नॉर्मल यूरिन वॉल्यूम पूछे तो कितना रहता, सो व्हाट इज द नॉर्मल यूरिन वॉल्यूम, सो द नॉर्मल यूरिन वॉल्यूम इट इज अराउंड 1 ml per kg per hour, right, 1 ml per kg per hour, that is a normal urine volume. ठीक है, right, now yes, I will reply to all of you whoever is texting me on my WhatsApp. Definitely I will reply to all those whoever is texting me on my WhatsApp. So don't worry about that. Immediately after the class, I will send you the link. Okay, so don't worry. Right, now let us just discuss the etiology of acute kidney injury. So the entire acute kidney injury I will revise in just 5 minutes. Okay, so we classify the acute kidney injury into pre-renal, intrinsic renal and post-renal. So pre-renal ये क्या होगा, व्हाट इज दिस प्री रीनल, सो प्री रीनल बोले तो अगर रीनल परफ्यूजन कम हो गया, किडनी के पहले अगर कुछ प्रॉब्लम के वजह से अगर किडनी डैमेज हो गया, दैट इज कॉल्ड प्री रीनल टाइप ऑफ acute kidney injury. So प्री रीनल it is due to decreased renal blood flow that will causing acute kidney injury is pre renal. अगर किडनी में ही प्रॉब्लम है, विद इन द किडनी देयर इज प्रॉब्लम, then that is nothing but your intrarenal type of acute kidney injury. अगर प्रॉब्लम किडनी के बाहर है, that is outside the kidney there is the problem, that will be right, that will be post-renal type of acute kidney injury. So this is what is your pre-renal, intrinsic renal and as well as post-renal. So yes, so pre-renal if you see, that is due to decreased renal perfusion. Now you should be able to differentiate. Okay, so this is due to what, this is due to decreased renal blood flow. Okay, so renal blood flow if you take कितना हो जाए, normally how much is the renal perfusion, 20% of the cardiac output will go to the kidney. Now how will you differentiate pre-renal from intrinsic renal, there are some parameters, right, so वो parameters क्या होगा, so in pre-renal if you take fraction excretion of sodium it will be less than 1, right, fraction excretion of sodium will be less than 1 in pre-renal. And intrinsic renal में कितना रहता, in intrinsic renal the fraction excretion of sodium will be more than 1. ठीक है, then blood urea nitrogen to the serum creatinine ratio. So in case of pre-renal the value is more than 20 in pre-renal. Intrinsic renal में क्या होगा, intrinsic renal the value of blood urea nitrogen to the creatinine ratio is around 10:15. And another parameter is the urinary sodium. Urinary sodium in pre-renal it is less than 10, whereas intrinsic renal it will be more than 20. And next important thing is the urine osmolality. So urine osmolality in pre-renal it is more than 500, बहुत ज़्यादा रहता. And intrinsic renal में the urine osmolality will be around 350. So these are the parameters, that is your fraction excretion of sodium, blood urea nitrogen to serum creatinine ratio, urinary sodium and urinary osmolality. These are the parameters which will differentiate pre-renal from intrinsic renal. Then coming to post-renal, post-renal क्या होगा, problem will be like ureteric stones, benign prostatic hyperplasia or bilateral, okay, bilateral ureteric fibrosis, bilateral ureteric fibrosis. So these are the causes for post-renal type of acute renal failure. ठीक है, then now there are three important phases in the acute kidney injury. One is initiation phase, that will be there for up to 36 hours. Then you have maintenance or oliguric phase in the acute kidney injury, that will be there for nearly around 1 to 2 weeks. And in maintenance or oliguric phase you will have all the complications related to uremia. So all the complications related to uremia will be there in maintenance or oliguric phase, and there will be maximal reduction in the urine output in maintenance or the oliguric phase. Then coming to recovery or diuretic phase. In recovery or diuretic phase, all the uremic complications, whatever you have in maintenance or oliguric phase, that will get corrected. Okay, so there will be, so all the features, all the uremic complications, that will be recovered. That will be recovered. Then what are the features of uremia? So uremia के वजह से problems क्या होगा? So uremia के वजह से, like urea will go and accumulate in the brain. Okay, that will result in uremic encephalopathy. Urea will come and accumulate within the pericardium, resulting in uremic pericarditis. Urea will come and accumulate within the GIT, resulting in uremic gastroparesis. Right? So these are all the various features of the uremia. And because of the fluid overload, the individual can develop hypertension, the individual can develop pericardial effusion and as well as pleural effusion also, that is, and the individual can also have pedal edema. So these are the features because of the fluid overload, right? So this is about your acute kidney injury. Then you take the investigations in patients with acute kidney injury. What is that? Urea levels will be elevated, serum creatinine levels will be elevated, and if you take the complete blood picture, you will have anemia. But for suppose, instead of, along with anemia, if there is eosinophilia in patients with acute kidney injury, then what you should suspect is, you should suspect atherosclerotic disease, right? You should suspect atherosclerotic disease causing acute kidney injury, right? So this is like the important features of acute kidney injury. Now let us discuss the treatment of acute kidney injury. Okay, so first and foremost, if the acute kidney injury is due to rhabdomyolysis, okay, that is due to muscle degeneration, then what is the treatment that you have to do? You have to do, the treatment of choice will be forced alkaline diuresis, राइट, फोर्स्ड अल्कलाइन डायूरेसिस. अगर वॉल्यूम ओवरलोड बहुत ज्यादा है acute kidney injury में, then in such case you have to restrict the water intake and you should give diuretic, that is furosemide, to flush out the water. Agar, and these patients with acute kidney injury, they may have symptomatic hyponatremia. And what type of hyponatremia is this? Can anyone tell me? Is it euvolemic hyponatremia or dilutional hyponatremia? Yes? Is it euvolemic or dilutional hyponatremia? So in these patients, because of the fluid overload, there will be dilutional hyponatremia. And because of that, so you have to restrict the water intake. Very good, Habiba. So you have to restrict the water intake. And if the individual is having symptomatic hyponatremia like seizures, then you should give hypertonic saline, that is 3% sodium chloride should be given. Then coming to hyperkalemia. See, potassium is the one important ion which has to be excreted through the kidney. And if kidney is damaged, potassium is not excreted out. So that will result in hyperkalemia. So what is the drug of choice for hyperkalemia? The drug of choice for hyperkalemia will be calcium gluconate. That will be calcium gluconate. But this calcium gluconate will not reduce the potassium levels. Calcium gluconate क्या कर सकते हैं? Calcium gluconate will sensitize the myocardium and will prevent the development of arrhythmias. Okay. And this, what are the drugs which will reduce the potassium levels? The drugs which will reduce the potassium levels will be, number one, your insulin plus dextrose. Right, insulin plus dextrose. And number two, salbutamol nebulization. Right, salbutamol nebulization. And number three, you should give furosemide. And if there is refractory hyperkalemia, then you should do hemodialysis. Okay, that is a treatment for hyperkalemia. Then coming to metabolic acidosis, that can happen in patients with acute kidney injury. And if the serum bicarbonate levels are less than 10, if the serum bicarbonate levels are less than 10, then you should give intravenous sodium bicarbonate. You should give intravenous sodium bicarbonate. And if the patient is having hypocalcemia, then in such case, you should give calcium carbonate or calcium gluconate should be given. Calcium carbonate or calcium gluconate. Then how will you treat this hyperphosphatemia? You should give phosphate binding agents. So what are these phosphate binding agents? These are sevelamer hydrochloride. These are the phosphate binding agents. And one more phosphate binding agent will be calcium acetate. That will be another phosphate binding agent. Then next is hyperuricemia. In patients with tumor lysis syndrome, there will be hyperuricemia. So how will you treat this hyperuricemia of tumor lysis syndrome? See, you have to give IV fluids, that is the normal saline. Then you have to excrete the uric acid, whichever is being formed. So how will you excrete that uric acid? You have to give uricosuric agent, that is rasburicase. Okay, and you should also reduce the uric acid synthesis. So how will you reduce the uric acid synthesis? For which you should give allopurinol. Okay, so this is about the medical management in patients with the acute kidney injury. Then what are the indications of dialysis in patients with acute kidney injury? Is that so if the patient develops hypertensive crisis, then you should give labetalol. Labetalol will be the drug which will reduce the blood pressure in the individual. Then you should know the indications of dialysis in patients with acute kidney injury. So you just remember this mnemonic, that is have P, right? Have P is a mnemonic. So hyperkalemia. What type of hyperkalemia? That is refractory hyperkalemia, right? The word A stands for what? Acidosis. What type of acidosis is that? Refractory acidosis. Then V, that is volume overload. What type of volume overload? Refractory volume overload. E stands for elevated blood urea nitrogen. So how much should be that blood urea nitrogen elevated? That should be elevated more than 35 millimoles per liter. And P stands for pericarditis, uremic pericarditis, do dialysis. E stands for encephalopathy, that is uremic encephalopathy. Please do dialysis. Then edema. What edema? Not pedal edema. It should be pulmonary edema. Okay, so these are the indications of dialysis in patients with acute kidney injury. So this finishes the topic of the quick revision of acute kidney injury. Now we will go back to this question. Now you please answer this. This was our first question. Patient of oliguria, urine osmolality 800 milliosmoles, urine sodium 10 millimoles per liter, blood urea nitrogen 20:1. So what do you think is the most likely diagnosis? I have just taught you differentiating points between pre-renal and as well as intrinsic renal. Yes? Now it is acute renal failure only, but what type of acute renal failure is this? So just please remember, it is very good, Ali Azad. It is pre-renal type of acute renal failure. So blood urea nitrogen to the serum creatinine ratio, what did we discuss? More than or equal to 20:1. And then what did we discuss about the urine osmolality in case of the pre-renal? In case of pre-renal, the urine osmolality will be more than 500, right? More than 500. So our patient is having 800. Then you take the urinary sodium. So urinary sodium, what did I tell you? In case of the pre-renal, it will be less than or equal to 10. It will be less than or equal to 10 millimoles per liter. So the answer is the pre-renal type of acute kidney injury. Okay, right. So those students who are unable to find my Telegram channel, as already I have said you can text me on my WhatsApp. This is my WhatsApp number. You can text me on my WhatsApp number. I will just send you my Telegram channel link. Okay, so don't worry about it at all. There you will be getting the PDF of the sessions. Right now, so after having discussed about acute kidney injury, now let me take up the discussion of the chronic renal failure. The next important topic will be chronic renal failure. Okay, right. So now if you take the chronic renal failure, how is your chronic renal failure defined? Chronic renal failure is being defined based on the glomerular filtration rate, whereas acute kidney injury was defined based on the urine output and serum creatinine. Whereas what should be the GFR to call it as the chronic renal failure? So GFR, it should be less than 30 ml. Okay, it should be less than 30 ml per minute per 1.73 meter square. And along with this, there should be also proteinuria. So this decreased GFR and proteinuria should be there for how long? It should be there for nearly more than or equal to 3 months. Okay, it should be there for more than or equal to 3 months. That is how we define this chronic renal failure. Now depending upon this GFR value, so entire chronic renal failure I'll just discuss in revise in 5 to 7 minutes. Okay, right. So this GFR, depending upon the value, we classify the stages also, right? So if you take the stages of chronic renal failure, so in stage 1 you have kidney damage but there will be normal GFR. How much will be that GFR in stage 1? More than 90. And in stage 2, you reduce the value by 30. That is 60 to 89 will be stage 2 chronic renal failure. Then you take 3A and as well as 3B. So in 3A, the GFR will be 45 to 59. And in 3B, the GFR will be 30 to 44. That means 3A, 3B, you reduce 15, 15. And in stage 4, you reduce the GFR again by 15 from your 3B. So how much will be that? 15 to 29. What is very important that you should remember here is when to call it as stage renal failure. When will you call end stage renal failure? When right. So when the GFR is less than 15, we call it as end stage renal failure. Okay? Right. So now what is the best method for estimating the GFR? So the best method for estimating the GFR will be the inulin clearance test. That is the best method for estimating the GFR. Now let me just quickly tell you about the points related to the chronic renal failure. Now, what is the most common cause of chronic renal failure? Most common cause of chronic renal failure will be diabetes mellitus, right? Most common cause will be diabetes mellitus. Then, in these patients with chronic renal failure, you will have the features of uremia, whatever you have in acute kidney injury, and you also have the features of the volume overload. That is your hypertension, pleural effusion, pericardial effusion, ascites, and pedal edema. And they will also have renal osteodystrophy. Why is this? Because of secondary hyperparathyroidism. Because in chronic renal failure, there will be hypocalcemia. Secondary to hypocalcemia, there will be increased release of parathormone, and that increased parathormone will cause bone resorption, resulting in renal osteodystrophy. And these patients, they will have anemia. What type of anemia they will have? Normocytic, normochromic type of anemia will be there. And why is that anemia? Due to erythropoietin deficiency. Now, regarding WBCs, what will be the problem? There will be decrease in the granulocyte function, and your WBCs are policemen of your body. So once there is decrease in your granulocyte function, these individuals are more prone for infections. Then there will be also decrease in the activity of the platelets, and platelets, once there is decrease in the activity of the platelets, the individual will have increased bleeding tendencies, so because of which there can be ecchymosis and all. Next, now because of this renal osteodystrophy and as well as anemia, these patients, they will have growth retardation, right? Growth retardation is due to anemia and renal osteodystrophy. And these patients, the urea will go and accumulate within the peripheral nerves, resulting in the peripheral neuropathy. Resulting in peripheral neuropathy. And gastrointestinal manifestations will be in the form of gastroparesis, where the individual can have constipation or diarrhea, and they will also have hiccups. Hiccups is another very, very important feature that you will come across in chronic renal failure. Then they will have dyslipidemia. Why is that these patients with chronic renal failure have dyslipidemia? That is because in chronic renal failure, there is decrease in the lipoprotein lipase activity. Right, due to decrease in lipoprotein lipase activity, there will be dyslipidemia. And these individuals, they'll also have genitourinary manifestations, and that genitourinary manifestations will be in the form of impotency, and there will be also isostenuria. Right, there will be also isostenuria. Then what will be the abnormality within the skin? So within the skin, there will be development of xerosis. There will be dryness of the skin, right? And underneath the skin, you have the extravascular accumulation of the fluid, resulting in edema. And because of the bleeding tendencies, if you see the skin, there will be ecchymosis. Because of the bleeding tendencies, there will be ecchymosis. And if you take the nails of these individuals, they will have this classical half and half nail. Okay, they'll have this classical half and half nail. And you know what is this half and half nail called as? This half and half nail, this is called as Lindsay's nail. Right, this is called as Lindsay's nail. I'll show you that. And what will happen to the kidney size in patients with chronic renal failure? The kidney size will be reduced, but there are some exceptions. What are those exceptions? In polycystic kidney disease, even though there is chronic renal failure, the kidney size will be increased. And not only that, in case of infiltrative pathologies like amyloidosis, okay, like amyloidosis, leukemia, lymphoma, in all these conditions, you know, even though they cause chronic renal failure, the kidney size will be increased. Okay, now this is what is exactly your half and half nail. Okay, this is what is called half and half nail. So you can see this very clearly, right? So your proximal half, it is pale or white, and the distal half, it is red. This is called Lindsay's nail. And they will ask you the question also, why do you get this half and half nail? So that is because of increased capillary density in the proximal half of the nail. Right, that is due to increased capillary density in the proximal half of the nail. Okay? Now I'll show you one quick question related to the treatment. Please answer this question. Okay, a 49-year-old woman attends your clinic suffering from chronic renal failure due to progressive glomerular disease. She appears well and her blood pressure is 141 by 92. Blood tests reveal elevated phosphate, serum creatinine, and as well as urea. Calcium levels are low, and her EGFR is 35. So EGFR 35 means she is in stage 3. You also notice the patient cholesterol levels are moderately raised. What is the most appropriate management in this patient? So what will you do in this patient? Please tell me. So you want to give sevelamer hydrochloride, or do you want to do parathyroidectomy, oral vitamin D, renal dialysis? So what will you do now? No, it is not renal dialysis. So when will you do renal dialysis? You will do renal dialysis when the patient is in end-stage renal disease. That is when the GFR is less than 15. That is the point when we do renal dialysis. It is not all the patients with chronic renal failure we will be doing the renal dialysis. You have to remember this very, very important point. So answer is not renal dialysis. Okay. Now, what are all the problems in our patient now? One problem is there is elevated phosphate. The other problem is there is low calcium levels, and as well as the elevated phosphate. So what is the primary thing here is, see, don't jump onto your oral vitamin D. See, you might be under the impression that, sir, calcium levels are low, so I will give vitamin D that will improve the calcium. No, that is not the correct thing. Why? I will tell you. See, if you give oral vitamin D, okay, yes, that will increase the calcium. But you know what this increased calcium will do? This increased calcium will combine with this increased phosphate, and that will form calcium phosphate precipitate. So again, your ionic calcium levels reduces. So what is your primary thing to do first? You have to reduce the serum phosphate levels. So how will you reduce that serum phosphate level? Just now I have taught you, that is, you should give sevelamer hydrochloride or you should give calcium acetate. That will reduce the serum phosphate levels. So after reducing the serum phosphate levels, then along with that you supplement your calcium gluconate or vitamin D. Okay, but the primary thing is reduce that phosphate. If you don't reduce that phosphate and if you keep on giving calcium, the calcium will get utilized in the form of the formation of calcium phosphate. So calcium, whatever you give, the ionic calcium levels keeps on decreasing. So what is the thing that you have to do here? Sevelamer hydrochloride. So the answer is A in this patient. Okay, right. Now you take the treatment now. So the treatment is that, what is the most common cause we have discussed? That is diabetes mellitus. So how will you treat this diabetes mellitus? You have to give insulin. Insulin will be the drug of choice for diabetes mellitus in chronic renal failure. Whatever it is type 1 or type 2 diabetes mellitus, if the individual has developed chronic renal failure, insulin will be the drug of choice. And by giving insulin, you have to ensure that The HbA1c should be maintained less than 7. The target HbA1c should be less than 7%. Then the next important thing is the blood pressure control. So how will you achieve this blood pressure control? So how will you achieve this blood pressure control is by giving calcium channel blockers. And how much is the target blood pressure? That should be less than 130 by 80 millimeters of mercury in patients with chronic renal failure. Then I said you that these patients will have dyslipidemia due to decrease in lipoprotein lipase activity. So you have to reduce the cholesterol. Your LDL should be less than 70, and for this you should give statins. Right, for this you should give statins. Then vitamin D you should supplement. Why is that? That is mainly to improve the calcium. And you should also reduce the phosphate. So how will you reduce the phosphate? Just now we have discussed, that is sevelamer hydrochloride, or you should give calcium acetate. Calcium acetate. Then the another important drug is cinacalcet. What is this cinacalcet? See, renal osteodystrophy is due to secondary hyperparathyroidism. So when you give the cinacalcet, what it will do is it will prevent the release of parathormone. The next important is treatment of anemia. So how will you treat anemia? By giving erythropoietin. So erythropoietin you have to give through subcutaneous route. Now what are the erythropoietin formulations? The erythropoietin formulations are the epoetin alpha, and then we have darbepoetin alpha. These are given through subcutaneous route. You have to give this twice weekly. Okay, so this completes the discussion of your chronic renal failure. So we are done with acute renal failure and chronic renal failure. Then followed by that, we will discuss renal replacement therapy. Okay, we will discuss renal replacement therapy. So how will you do renal replacement therapy? By two methods. One, you will do dialysis. The other method of renal replacement therapy will be kidney transplantation. Okay, so now first in the dialysis, let me discuss about the hemodialysis. And whenever you are planning to do hemodialysis in a chronic renal failure patient, you have to create a fistula. And what is the name of this fistula? The name of this fistula will be Seminobrecia fistula. Right, the name of the fistula will be Seminobrecia fistula. Now what is the advantage of creating the fistula? The advantage is mainly to reduce the incidence of thrombophlebitis. So basically what you will be doing by creating the fistula is you will be doing the arterialization of the venous system. So thereby there will be decreased incidence of thrombophlebitis, right? Now what is the principle of hemodialysis? It will follow the counter current mechanism. And what is the most common complications of hemodialysis? That will be hypotension. So why is that hypotension? Because you are taking out large quantity of the fluid from the body and then you are sending it to the dialyzing machine. So the fluid level in the body reduces, that will result in hypotension. Then, what is the most common complication of the recurrent hemodialysis? Most common complication of recurrent hemodialysis will be accelerated atherosclerosis. Then, these patients who are undergoing dialysis for longer time, they also develop dialysis dementia. What is the cause for dialysis dementia? The cause for dialysis dementia is due to accumulation of amyloid beta 2 protein. Okay, due to accumulation of amyloid beta 2 protein within the brain, that will result in dialysis dementia. And this amyloid beta 2 protein will also accumulate in the flexor retinaculum, and that will result in development of carpal tunnel syndrome. Okay, and whenever the patient is undergoing dialysis, there will be washout of B7. I'm sorry, there will be washout of your pantothenic acid. Right, there will be washout of pantothenic acid, those patients who are undergoing hemodialysis. So once there is washout of pantothenic acid, the individual will develop burning feet syndrome. Okay, so these are some quick important points related to hemodialysis. And this dialysis we do in two methods. One is peritoneal dialysis and the other one is hemodialysis. Peritoneal dialysis is a slow process, hemodialysis is a fast process. And peritoneal dialysis you can do it in the home as well, whereas hemodialysis you have to do it in the hospital usually, right? And what is the very important difference between these two is that in case of the peritoneal dialysis, the peritoneum itself will be acting as the artificial membrane. Peritoneum itself will be acting as a membrane for the filtration. But whereas here, in case of hemodialysis, we will be using semi-permeable membrane. Right, we will be using semi-permeable membrane for the dialysis. Okay, so that is the difference between the peritoneal and hemodialysis. Right now, so one method of renal replacement therapy I have taught you, that is dialysis, and the other method of renal replacement therapy is the kidney transplantation. Now, which particular kidney you have to, okay, which group of individuals you have to select for donating the kidney. So allogenic kidney transplantation should be done. That means the kidney should be taken from the first degree relative, and whenever you are doing the kidney transplantation, you have to do HLA matching between the two individuals, for which the gene is located on chromosome 6, and you also have to do blood grouping, right, blood grouping between the two individuals, and for blood grouping the gene is located on the chromosome 9. Okay, and what all have to be tested in the donor? The donor have to be tested for the HIV, all the viral infections, the HBV, then HCV, and then cytomegalovirus. Donor has to be tested for all these infections. And what the recipient has to be tested for? The recipient has to undergo renal Doppler. What is the purpose of undergoing renal Doppler? That is mainly to rule out renal artery stenosis. That is mainly to rule out renal artery stenosis. Now, which kidney of the donor has to be taken? So, it is usually the left kidney from the donor has to be taken. Why is that? Because the left renal vein is longer. So, that is the reason why the left kidney from the donor has to be taken. And where it has to be placed in the recipient? In the recipient, it has to be placed in the right iliac fossa. Okay, it has to be placed in the right iliac fossa. Okay, now then whenever the kidney is placed in the right iliac fossa of the recipient, do you think that recipient will accept the transplant? No, immediately there is chance of rejection. Immediately there is chance of rejection. So we have three types of rejections. One is hyperacute rejection, which is a type 2 hypersensitivity reaction. Can anyone tell me what do you mean by this type 2 hypersensitivity reaction? Yes. What is type 2 hypersensitivity reaction? This type 2, your hyperacute rejection, it occurs within few minutes of anastomosis. Right? It occurs within few minutes of anastomosis. And what is this type 2 rejection? That is nothing but cytotoxic. That is antibody mediated. Whereas if you take acute rejection is the one which occurs within the first 6 months of surgery. Within first 6 months of surgery, if the rejection occurs, that is acute rejection, and 6 months, it's a delayed process. So it is type 4 hypersensitivity reaction. And what is chronic rejection? Chronic rejection is the one which occurs after 6 months of the transplant. And this is also your type 4 hypersensitivity reaction. Then to prevent the rejection, what you will do, you have to give the immunosuppressants. What are these immunosuppressants? These immunosuppressants, just remember the mnemonic, that is CAP. What is CAP? The C stands for cyclosporin, A stands for azathioprine, P stands for prednisolone. Okay, cyclosporin, azathioprine, and prednisolone. So these are the drugs which we give. These are immunosuppressants that will prevent the rejection. But the problem is that whenever the individual is started on immunosuppressants, the individual is at increased risk of the opportunistic infections. Okay, so what will be that opportunistic infections? Like Metzl infection with MRSA, herpes simplex infection, viral infections like cytomegalovirus, HBV, and HCV virus. So these are the infections that the individual is prone for. So this is about your renal replacement therapy. So this is done. So two methods of renal replacement, dialysis and then kidney transplantation. Okay, right. Now, after having discussed about the renal failure. We have discussed acute kidney injury, chronic kidney or chronic renal failure, and then we have discussed renal replacement therapy. Now, next, let me discuss quickly about renal tubular acidosis. We have totally three types, that is type 1, type 2, and as well as type 4 renal tubular acidosis. And in all these patients with renal tubular acidosis, they will have normal anion gap. Right, they will have normal anion gap, which is nothing but around 8 to 12 milliequivalents per liter. That is a normal anion gap. So it is the one which is characterized by hyperchloremic normal anion gap metabolic acidosis. Now, where exactly will be the defect? In type 1 renal tubular acidosis, the defect is in the distal part of the tubule. It is not distal convoluted tubule, it is a distal part of the tubule, that is at the level of collecting duct, where there will be failure of secretion of the H plus ion. Okay, so at the level of your collecting duct, there should be secretion of H plus. That does not happen in type 1 renal tubular acidosis. Then what is the problem in type 2 renal tubular acidosis? In type 2 renal tubular acidosis, at the level of proximal convoluted tubule, there should be absorption of bicarbonate. So in type 2 renal tubular acidosis, there is failure of absorption of bicarbonate at the level of your proximal convoluted tubule. That is what is your type 2 renal tubular acidosis. So your type 2 renal tubular acidosis, the pathology will be at the level of PCT, where there is failure of absorption of bicarbonate. Then what is the defect in type 4 renal tubular acidosis? That is due to decrease in aldosterone, right? That is due to decrease in aldosterone or due to aldosterone resistance. Due to decrease in aldosterone or due to decrease in or due to aldosterone resistance. So once there is no aldosterone, the H plus ion secretion at the level of DCT does not occur, and that will result in acidosis. Okay, right. Then what will happen to the urinary pH? In case of type 2 renal tubular acidosis, the urinary pH will be less than 5.5. But whereas in type 1 and type 2, it will be more than 5.5. The alkaline urine will be there in type 1 and type 2. Then you take the bicarbonate which is excreted. Maximum amount of bicarbonate is excreted in type 2 renal tubular acidosis. That will be more than 15 milliequivalents, because the problem itself is what? That is failure of bicarbonate reabsorption at the level of PCT. So the bicarbonate, urinary bicarbonate levels will be more than 15%. Whereas in type 1 it is less than 10, and in type 4 also it will be less than 10. Coming to the serum potassium levels, this is another very important question. Okay, so in type 4 renal tubular acidosis, there is aldosterone deficiency or aldosterone resistance. And what is the function of aldosterone? Potassium secretion and excretion of potassium. When aldosterone is not there, the potassium is not excreted out. So that will result in the hyperkalemia. Whereas in type 1 and type 2, there will be hypokalemia. Right, in type 1 and type 2, there will be hypokalemia. Then coming to Fanconi's syndrome. So which is called as Fanconi's syndrome? Your type 2 renal tubular acidosis, where pathology is at the PCT, that is called Fanconi's, whereas not your type 1 and type 4. Then coming to renal stone formation, this is another very important point. Renal stone formation is very specific in type 1 renal tubular acidosis, but not in type 2 and as well as type 4 renal tubular acidosis. Okay, so nephrocalcinosis is very clear in type 1 renal tubular acidosis. Then coming to the urinary anion gap. So all these conditions, the urinary anion gap will be positive. Urinary anion gap will be positive. Then you take the etiology of type 1 renal tubular acidosis. We have some drugs. What are those drugs which will cause type 1 renal tubular acidosis? That will be amphotericin B. Right, that will be amphotericin B or your paraproteinemias. Then you take type 2 renal tubular acidosis. The drug which will cause type 2 renal tubular acidosis is acetazolamide, which is a carbonic anhydrase inhibitor. And your type 4 renal tubular acidosis is caused by your ACE inhibitors or angiotensin receptor blockers. Then how do you treat? See, in all these renal tubular acidosis, you should supplement bicarbonate. In type 1, you should give 1 to 2 milliequivalents per liter of sodium bicarbonate per day. Okay, 1 to 2 milliequivalents per kg. Whereas in type 2 renal tubular acidosis, you should give very high amount of bicarbonate. Why? Because there is bicarbonate loss in type 2. So you should give 10 to 15 milliequivalents per kg of sodium bicarbonate in type 2, whereas in type 3 renal tubular acidosis, it is due to aldosterone deficiency. So you should give the aldosterone analog, and that aldosterone analog will be fludrocortisone. Okay, that will be fludrocortisone, right? So this is about quick recap of all the forms of renal tubular acidosis: type 1, type 2 and type 4. Type 3 is a rare condition, and in type 3 you have a mixture of type 1 and type 2 features. Okay, right? So that finishes your renal tubular acidosis. Okay, right? Next, yes. Now we will discuss the two important syndromes in kidney, that is nephrotic syndrome and nephritic syndrome. Yes. Anyone want to make a quick attempt of this question? All of the following are decreased, right? All of the following are decreased in nephrotic syndrome except all of the following are decreased in nephrotic syndrome except. Very good. So yes, it is your fibrinogen. So fibrinogen levels, they are not decreased. So what will happen to fibrinogen levels? Fibrinogen levels are increased in patients with the nephrotic syndrome. Okay? The remaining all will be reduced. Now let me discuss in detail about the nephrotic syndrome, right? So if you take nephrotic syndrome, what are the very important features is, in patients with nephrotic syndrome, they will have a proteinuria of more than 3.5 grams per 24 hours. Okay, and out of this proteinuria of more than 3.5 grams per 24 hours, the predominant protein that is being lost is albumin. So that is the reason why they will have hypoalbuminemia, and albumin is a very important protein that will maintain the oncotic pressure within the vessel. When albumin is out, the fluid from the vascular intravascular compartment will enter into the extravascular compartment. That will result in edema, and these patients, they will also have hyperlipidemia, lipiduria and hypercoagulability. Why is that? That is because of increase in the liver synthetic capacity. Because there is decrease in albumin in the body, liver will try to increase the synthesis of albumin. But what will be the synthetic capacity of the liver? Along with albumin, liver will also synthesize lipoproteins, that is LDL and VLDL, and that will cause the hyperlipidemia, causing lipiduria. And liver will also synthesize coagulation factors in excess quantity. So when liver synthetic capacity increases, even there is increase in your coagulation factor synthesis, resulting in the hypercoagulability. So the predominant protein that is being lost will be albumin. But not only albumin, there are many other proteins which are being lost in nephrotic syndrome. That includes the globulin. Now globulin, what is the important function of the globulin? That is the synthesis of immunoglobulins. And once the globulins are excreted out, the individuals are more prone for infections. Why is that? Because there is no immunoglobulin synthesis. Next, ceruloplasmin, which is required for maintenance of adequate copper metabolism. And when ceruloplasmin is kicked out in nephrotic syndrome, the individual can develop excessive accumulation of copper, and the feature will be similar to that of the Wilson's disease. Then transferrin. Transferrin is what? It is the one which is required for transportation of iron, and once the transferrin protein is lost, the iron transportation does not occur, and the individual will develop microcytic hypochromic anemia, right? Microcytic hypochromic anemia. And there is also loss of the natural anticoagulants in our body, and they are also proteins. What are those? Antithrombin 3, protein C, protein S. They are all natural anticoagulants. They're all natural anticoagulants, and these are also lost. And once these are lost, the individual will develop hypercoagulability. Okay, and the coagulation factors which are excessively synthesized are, there will be increase in the fibrinogen levels, right? And there will be also increase in your prothrombin levels. There will be also increase in the labile factor, that is factor number 5. There is also increase in the stable factor, and there will be also increase in the synthesis of the anti-hemophilic factor, and there is also increase in the synthesis of the fibrin stabilizing factor, sorry, the Haseman's factor, and there is also increase in the synthesis of the fibrin stabilizing factor. So these are all the coagulation factors which are elevated in nephrotic syndrome. This is a very, very important multiple choice question. Okay, right. Okay, Ankit Pandey, just now I was just telling in the session also, if you are unable to get my Telegram channel, please text me on my WhatsApp number. I will send you the Telegram link after the class. Once the class is over, you just text me on my WhatsApp number, then I will send you the Telegram link. Okay, right. Then cholecalciferol binding protein, that is also lost in patients with the nephrotic syndrome. What is this cholecalciferol binding protein? That is the one which is required for the carrying of vitamin D, which is synthesized at the kidney to the intestines, which is required for absorption of calcium. So when your cholecalciferol binding protein is lost, there will be decrease in the calcium levels, and there will be also loss of thyroxine binding globulin, and that will result in abnormalities related to the thyroid. Okay, so these are all the proteins which are being lost in nephrotic syndrome apart from albumin. Definitely it is the albumin which is predominantly lost. Apart from albumin, these are the other proteins which are being lost. Okay, right. Now we will discuss what are the various types of nephrotic syndrome. So, a 7-year-old boy presented with generalized edema. Urine examination revealed marked albuminuria. Serum biochemical examination showed hypoalbuminemia with hyperlipidemia. What did the kidney biopsy? Kidney biopsy showed light microscopy appeared normal. So, what will the electron microscopy most likely reveals? Any one of you? What will the electron microscopy reveals? Yes. Yes, very good, Ali Azhar. So it is the fusion of the food processes. Fusion of the food process. So what is this suggestive of? This is suggestive of minimal change disease. Now let me discuss all the forms of the nephrotic syndrome. Right. So I revise entire nephrotic syndrome, all the type etiologies of nephrotic syndrome in just 5 minutes. Okay? Right. Now, diabetic nephropathy. So diabetic nephropathy, it is the most common systemic disease. Right? Diabetic nephropathy, it is the most common systemic disease that will be responsible for your nephrotic syndrome. Minimal change disease, that is the most common cause of nephrotic syndrome in children and as well as young adults. And focal segmental glomerulosclerosis, that is the most common cause of nephrotic syndrome in adults. And membranous glomerulonephritis, if you see, that is the most common cause of nephrotic syndrome in elderly individuals. Okay, now what is important in all these conditions? That is biopsy. In all these conditions, the investigation of choice will be biopsy. So what will the light microscopy, electron microscopy, fluorescent microscopy, and what is the treatment in all these conditions is very important. Now you take in diabetes mellitus. In diabetes mellitus, you have two forms. One is diffuse glomerulosclerosis. The other one is nodular glomerulosclerosis. Which is more common between these two? Diffuse glomerulosclerosis is more common than nodular glomerulosclerosis. What is that you will observe in diffuse glomerulosclerosis in the light microscopy? You will observe that there is thickening of glomerular basement membrane, and this thickening of the glomerular basement membrane is the earliest change in case of diffuse glomerulosclerosis. And you also have various exudative lesions in diffuse glomerulosclerosis, that is capsular drops and as well as the fibrin caps. Then nodular glomerulosclerosis. Nodular glomerulosclerosis, this will be pathognomic for, right, this will be pathognomic for diabetic glomerulosclerosis, and you have nodular lesions, and these nodular lesions, they are called as Kimmel-Steele-Wilson's lesions, right? And this will give you this is called nodular glomerulosclerosis, or it is also called as intercapillary glomerulosclerosis. It is also called as intercapillary glomerulosclerosis. Okay, right. Then how do you treat? See, what is the earliest manifestation of diabetic glomerulosclerosis? There will be microalbuminuria. So when do we use the word microalbuminuria? When the albumin which is excreted is around 30 to 300 milligrams per 24 hours. That is the point when we use the word microalbuminuria. And what is the drug of choice for this diabetic nephropathy? That is AC inhibitors. And why we should give AC inhibitors? Because they will reduce the intraglomerular pressure. So that is about your diabetic nephropathy in crisp manner. Okay. Next, coming to minimal change disease. So minimal change disease also, the investigation of choice will be biopsy. And when you do biopsy in minimal change disease, light microscopy, there is no abnormality at all. But electron microscopy, you will observe that there is fusion of the food process. There is fusion of the food process. And in electron microscopy, you will have the fusion of the food process. Okay. And in fluorescent microscopy, there is no immunoglobulin or complement. That is what you'll observe in minimal change disease. Then, what is the drug of choice in minimal change disease? That will be steroids. We give prednisolone. Okay, so how much of prednisolone we give? 1 to 1.5 milligrams per kg body weight. But when you give prednisolone for longer duration of time, the individual may develop the Cushingoid appearance. So in order to avoid the toxicity with steroids, we taper and stop steroids, then we give cyclophosphamide. Right, we give cyclophosphamide, right? And some patients, they are steroid resistant nephrotic syndrome. So in steroid resistant nephrotic syndrome, you should give cyclosporin. Right, you should give cyclosporin. Okay, that is a very important point and important nutshell revision of your minimal change disease. Then coming to focal segmental glomerulosclerosis. Light microscopy in focal segmental glomerulosclerosis, you will observe that, see, in FSGS, it is not the entire glomerulus which will undergo sclerosis. It is only the part of the glomerulus. So in light microscopy, what will you observe? You will observe that the part of the glomerulus will undergo sclerosis. And electron microscopy will show you the presence of the hyaline deposits. Electron microscopy will show you the presence of hyaline deposits. Not only hyaline deposits, electron microscopy will also show you that these podocytes, right, the food process of the podocytes, they are effaced. The podocytes, they are detached. That is what you will observe in electron microscopy. Then coming to the fluorescent microscopy. In fluorescent microscopy, there is no IgG or complement. Then how do you treat this FSGS? You need to give immunosuppressive therapy. And what is that immunosuppressive therapy? You should give oral prednisolone. That is considered as the drug of choice. And those individuals who are resistant to prednisolone, who are intolerant to your prednisolone, in them you should give calcineurin inhibitor, and that calcineurin inhibitor will be cyclosporin. Or you can also give mycophenolate mofetil. So that is about your FSGS. So light microscopy, you will observe that it is only the part of the glomerulus which will undergo glomerulosclerosis. And electron microscopy, you will observe the hyaline deposits and podocytes, they are effaced, detached, and there is vacuolization. And drug of choice will be steroids. Those individuals who are resistant to steroids, you should give cyclosporin or mycophenolate mofetil. Then coming to membranous glomerulonephritis. Okay, one important point about FSGS is that these patients with FSGS, they have the features of nephrotic syndrome, and they also have the features of nephritic syndrome. That means usually in nephrotic syndrome, you don't have hematuria, but in patients with FSGS, they also have hematuria. So if the question is asked, which is the form of nephrotic syndrome where you will have hematuria, your answer should be focal segmental glomerulosclerosis. Then coming to membranous glomerulonephritis. So membranous glomerulonephritis, if you observe, it is seen in elderly individuals. And what will be the presentation of membranous glomerulonephritis? The presentation will be in the form of renal vein thrombosis. That will be in the form of renal vein thrombosis. Almost 40% of patients with membranous glomerulonephritis, they develop this renal vein thrombosis. And if you take light microscopy in membranous glomerulonephritis, light microscopy, you will observe that there is diffuse thickening, right? There is diffuse thickening of glomerular basement membrane. Diffuse thickening of glomerular basement membrane. Okay, and electron microscopy, what it will show you in membranous glomerulonephritis, the diffuse thickening is due to subepithelial deposits. It is due to subepithelial deposits. Fluorescent microscopy will show you that there is IgG and as well as C3, right? Yeah, yes, Abhishek Nath, you are correct. Even MPGN, membranoproliferative glomerulonephritis, you will have nephritic and nephrotic features. But in MPGN, nephritic features are more predominant than nephrotic features. Whereas in focal segmental glomerulosclerosis, nephrotic features are more than compared to that of the nephritic features. Okay, that is the difference between these two. Right. Then what is the treatment in patients with membranous glomerulonephritis? Along with steroids, you should also give other immunosuppressants like cyclophosphamide. Okay. Or you should also give even cyclosporin. Okay, so this is about your membranous glomerulonephritis. So this finishes your nephrotic syndrome. So within 10-15 minutes, we are completely done with the nephrotic syndrome, right? Now, you see this question. A 21-year-old man presents with lethargy over the last week. He has periorbital edema and proteinuria. The patient mentions he has been to hospital a number of times in the past to same symptoms as well as the mild eczema. Light microscopy of renal biopsy showed normal morphology. Electron microscopy revealed diffuse effacement of the epithelial podocytes. So what is the most appropriate treatment in this patient? Yes, what is the most appropriate treatment in this patient? Anyone want to make a quick attempt of this question? Very good, Rachna. So it is the oral prednisolone. What is the diagnosis here? The diagnosis of this clinical scenario is the minimal change disease. Okay, what did I tell you? It is seen in children and as well as young adults. Can anyone tell me what is the definition of a young adult? What is the age group to call it as young adult? So the definition to call it as the young adult is the age of the individual can be up to 40 years. Okay, the definition of young adult is the age of the individual can be up to 40 years. That is what is called as the young adult. Our patient's age is 21 years. So that can fit for your minimal change disease. Okay, so drug of choice in minimal change disease will be prednisolone. Right, you take this next. 19-year-old man is recently diagnosed with type 1 diabetes mellitus and attends your clinic to ask about possible complications in the future. He mentions an uncle who had end-stage renal disease due to poorly controlled diabetes and specifically inquires about testing for early signs of renal impairment. So what do you think is the most appropriate investigation in this patient? Yes, Shubham Gaurav, this session will be useful even for NEET PG as well. Okay, because for NEET PG or FMGE or next, the syllabus is the same. There is no change in that, right? Okay, so yes, so the patient is having the poorly controlled, right? So what will be the early signs of renal impairment? Very good. So the answer is what? Microalbuminuria. The answer will be micro. That is what we have discussed in diabetic glomerulosclerosis. So what will be the drug of choice in this patient now? What will be the drug of choice in this patient? So drug of choice in these individuals will be what? That is AC inhibitors. What these AC inhibitors will do? Not insulin, Amit, it is AC inhibitors. Okay, what these AC inhibitors will do? They will reduce the intraglomerular pressure and thereby they will reduce the proteinuria. Okay, so this is about your nephrotic syndrome. Now you see another important question. Yes, please answer this. When we have to choose for the answer C, what is their answer? Option C. That is serum creatinine. Okay, so now this serum creatinine elevation will not be quick. The patients with diabetic nephropathy, they will land up in renal failure. Type 1 diabetic patients, they take up to 5 to 10 years. for the development of renal failure, whereas type 2 diabetics, they take up to 10 to 20 years for the development of renal failure. So after 5 to 10 years of type 1 diabetes mellitus, when they develop renal failure, you check for the serum creatinine. For type 2 diabetics, it takes 10 to 20 years for the development of diabetic nephropathy, that is renal failure, where you can check the serum creatinine at that point. Okay. Yes, Rachna, is that clear, Rachna? Okay. So next is about the crescent formation. So crescent formation is characteristic of the following glomerular disease. Okay, so very good. So that is rapidly progressive glomerulonephritis. Now what is this crescent formation? It is half moon shaped collection of cells. Right, it is half moon shaped collection of cells. So what are the cells which will be accumulated here? That will be the inflammatory cells, that is your macrophages, right, or even your neutrophils or lymphocytes will be accumulated in this place. Okay, so that is about your crescent formation, which is very classical in RPGM. So now let us discuss quickly about the nephritic syndrome. So in nephritic syndrome, what is the proteinuria? It is subnephrotic proteinuria. That is, proteinuria will be around 3 grams per 24 hours. The proteinuria will be around 3 grams per 24 hours. Okay, then what will the urine analysis show? The urine analysis will show you the hematuria. That means you will notice that there is RBC, there will be RBC cast, not only RBC and RBC cast, there will be also WBC, that is inflammatory cells also will be there in the urine analysis. And these patients, they will also have oliguria. Okay, what is this oliguria? What should be the urine output to call it as oliguria? The urine output should be less than 400 ml per 24 hours. Right, less than 400 ml per 24 hours. That is when we use the word oliguria. Okay, so these are the important features of nephritic syndrome. And how will be the urine color? So there will be gross hematuria, and particularly in patients with post-streptococcal glomerulonephritis, they present with a cola colored urine. Right, they colored with cola colored urine. Right. Yes, Manjulata, there I did not discuss nephrology. If you see the videos there, I did not revise nephrology there. So you can just watch this particular video for nephrology quick revision. Okay. Right. Now, what are the etiologies that will be causing the nephritic syndrome? So there are many etiologies, but let me discuss important etiologies like IgA nephropathy or Burgers, then post-streptococcal glomerulonephritis, and then good pastures. These three are very, very important. Now, in all of these, like what will be the presentation? See, in all of these, they will have hematuria. There is no doubt in that. But when you do urine analysis, the urine analysis will show you that the feature suggests you of nephritic. But how will you differentiate one from the other? By doing biopsy. So when you do light microscopy in patients with IgA nephropathy, which is nothing but Burgers, you will notice that there will be mesangial proliferation. Right? There is mesangial proliferation. That is the reason why it is also called mesangial-proliferative glomerulonephritis. And electron microscopy in case of IgA nephropathy will show you that there is mesangial and as well as paramesangial deposits. Right, mesangial and as well as the paramesangial deposits. Okay, and fluorescent microscopy, it will show you that there is presence of IgA within the mesangium. Not only IgA, presence of C3 within the mesangium. The presence of IgA within the mesangium, it is the sine qua non for diagnosis. That means it is pathognomic for diagnosis of IgA nephropathy. You have to remember that in IgA nephropathy, the serum IgA levels, there is no role in the diagnosis. Serum IgA levels, there is no role in the diagnosis. Serum IgA levels, they may be even normal. Serum IgA levels, they may remain normal. Serum IgA levels, there is no role at all. Okay, but it is the renal parenchymal IgA under fluorescent microscopy. That is your pathognomic or sine qua non for the diagnosis. Then how do you treat this IgA nephropathy? So you should give the combination of steroids. It is not just only steroids. Along with steroids, you should also give cyclophosphamide. Okay, steroids and cyclophosphamide. So this combination you have to give it for nearly around 3 months. You have to give it for nearly around 3 months, and followed by this combination you should give azathioprine, and this azathioprine should be given for nearly around 2 years. This azathioprine should be given for a minimum of 2 years. Okay, so this is about your IgA nephropathy or the Buerger's disease. Then coming to post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, when you do a biopsy, what will the light microscopy show? Light microscopy in the PSGN, that will show you that there is diffuse proliferative glomerulonephritis. Okay, and there will be also infiltration of the leukocytes. There will be also infiltration of the leukocytes. And which leukocytes? That is neutrophils. And you have the deposits within the mesangium. So in the light microscopy, you can observe the classical starry sky appearance. You will have this classical starry sky appearance. Now coming to the electron microscopy. Electron microscopy, you will observe that there is dome-shaped subepithelial deposits. Right, dome-shaped subepithelial deposits. That is what you will observe in the electron microscopy of post-streptococcal glomerulonephritis. And fluorescent microscopy, you will have IgG and as well as C3 in the post-streptococcal glomerulonephritis. And treatment is completely symptomatic treatment. You don't have any specific drug which will completely reverse your PSGN. If there is hypertension, you give labetalol or calcium channel blocker. Okay, and if the individual is having oliguria, you treat accordingly by giving diuretics. So only symptomatic treatment is what you see in case of PSGN. Okay? Then coming to your Goodpasture syndrome. But before going on to this, you should know the differences between IgA nephropathy and as well as the PSGN. Now, can anyone tell me in between these two, the recurrence is more common in any one of you? Yes, any one of you please. In which type of IG, is it IG or post-streptococcal glomerulonephritis? Where is the recurrence more common? Where is the recurrence more common? So please remember, the recurrence is more common in IgA nephropathy. Whereas post-streptococcal glomerulonephritis, there is no recurrence at all. There is no recurrence at all. But in IgA, the recurrence is very common. Then you take the complement. The serum complement level, the C3 levels will be normal. The serum complement levels in IgA nephropathy, it will be normal. But whereas in post-streptococcal glomerulonephritis, the serum C3 level will be reduced. Serum C3 levels will be reduced in post-streptococcal glomerulonephritis. Then the next very important difference is the ASO titer. In IgA nephropathy, the titer appears absolutely normal, but in post-streptococcal glomerulonephritis, the ASO titer will be elevated. So these are the differences between IgA nephropathy and post-streptococcal glomerulonephritis. So I show you a table of differences between these two. Right, you can check this. So in IgA nephropathy, there will be onset of hematuria within 2 to 4 days of upper respiratory tract infection. Whereas in post-streptococcal glomerulonephritis, the hematuria will be there within 7 to 21 days following upper respiratory tract infection or skin infection. Serum complement levels in IgA nephropathy absolutely normal. But whereas in post-streptococcal glomerulonephritis, the complement is utilized, so thereby the serum C3 levels will be decreased. And recurrence is very common in IgA and recurrence is rare in PSGN. And there is no ASO titer being increased in IgA, but there is elevation of ASO titer in case of PSGN. And you have to remember that because the recurrence is very common in IgA nephropathy, 20 to 40% of patients they develop renal failure. 20 to 40% of patients with IgA nephropathy they develop renal failure. Whereas in PSGN, how is the prognosis? Because the recurrence is not there, so there will be good prognosis in patients with the post-streptococcal glomerulonephritis. Okay? So that is about your the differences between IgA nephropathy and as well as post-streptococcal glomerulonephritis, which will cause nephritic syndrome. The other important condition which will cause nephritic syndrome is Goodpasture syndrome. So Goodpasture syndrome is what? It is an autoimmune condition. Even though it is autoimmune, it is more common in males rather than females. Usually autoimmune conditions are more common in females rather than males, but here autoimmune, even though it is autoimmune, it is more common in males rather than females. So ratio is almost 6:1. And when I'm using the word autoimmune, the antibodies are being formed. And you know the antibodies, they are formed against alpha 3 chain of type 4 collagen. Alpha 3 chain of type 4 collagen. And this alpha 3 chain of type 4 collagen is present within the glomerular basement membrane, that is kidney. And this alpha 3 chain of type 4 collagen is also present in alveolar basement membrane, that is lung. So because the antibodies are formed against the kidney, the patient will present with hematuria. Because the antibodies are formed against alveolar basement membrane, the patient will present with hemoptysis. So it is a multi-system disorder. Kidney and as well as lung, both are being affected here. Presentation will be in the form of hematuria and as well as the hemoptysis. Then how will you diagnose? See, diagnosis is that you have to check the anti-glomerular basement membrane antibodies. In 90% of them, the anti-glomerular basement membrane antibodies will be positive. Then again, what is the gold standard for diagnosis of your Goodpasture syndrome? That will be renal biopsy. So in all these, either you take nephritic syndrome or nephrotic syndrome, the gold standard for diagnosis will be renal biopsy. So in Goodpasture syndrome, what will the typical pattern will be? The typical pattern will be in the form of diffuse, right? Will be in the form of diffuse proliferative glomerulonephritis. Okay, diffuse proliferative glomerulonephritis. And there can be also presence of crescents, but crescents are present in more than 50% of glomeruli. Crescents are present in more than 50% of glomeruli. Then how do you treat these patients with the Goodpasture syndrome? See, you have the antibodies, and that antibodies are the one which are destroying your alveolar basement membrane and glomerular basement membrane. So how will you clear these antibodies? You have to clear these antibodies by doing plasmapheresis. So when you do plasmapheresis, the antibodies that will be cleared, right? When you do this plasmapheresis, these plasmapheresis will remove the antibodies. Then how will you prevent the new antibody formation? So in order to prevent the new antibody formation, you should give steroids and as well as azathioprine. These are the immunosuppressive agents. They prevent the new antibody formation. That is steroids and as well as the azathioprine. And apart from the steroids and azathioprine, what is the other alternative treatment? The other alternative treatment is steroids plus cyclophosphamide. Steroids and cyclophosphamide. Now we have one more question. If the individual is refractory, right? If there is refractory Goodpasture syndrome, that means not responding to medical management at all. So in these individuals, you should give rituximab. In these individuals, you should give rituximab. Okay, so rituximab is considered as the drug of choice for refractory cases in case of Goodpasture syndrome. So that finishes your nephritic syndrome. So mainly you should remember these three conditions causing nephritic syndrome, that is post-streptococcal glomerulonephritis, IgA nephropathy, and as well as the Goodpasture syndrome. So we are done with the nephrotic syndrome and we are done with the nephritic syndrome. Then what is left out in the nephrology is the polycystic kidney diseases. So we have the autosomal dominant and as well as the autosomal recessive type of polycystic kidney diseases. So within 10 minutes or within 5 minutes, not in 10 minutes, within 5 minutes, I'll quickly recap the entire polycystic kidney diseases. So polycystic kidney disease, you have two types of inheritance, autosomal dominant and autosomal recessive. Okay, but which is the most common method of inheritance? That is autosomal dominant type of inheritance is most common than autosomal recessive type of inheritance. Okay, autosomal dominant is more common, and this autosomal dominant is more common in adults, and that is the reason why we call it as autosomal dominant polycystic kidney disease. This we call it as ADPKD. Okay, and this ADPKD is due to what? It is due to gene mutation. What is the genes that are being mutated? So the genes which are being mutated is PKD1 and as well as PKD2. So PKD1, where is this particular gene present? It is present on chromosome 16. PKD2, this gene is present on chromosome 4. And this PKD1, it will code for polycystin 1. Whereas PKD2, this will code for polycystin 2. Okay, so because of the defect in PKD1 and PKD2, the individual will develop this autosomal dominant polycystic kidney disease. Then what will be the clinical features? See, the kidneys are enlarged. If you see the kidneys here, they are like enlarged kidneys. So the capsule around the kidney, it is being stretched. Can anyone tell me what is the name of the capsule around the kidney? Now, once the capsule around the kidney is being stretched, the individual will have pain, and that is there will be loin pain. Right, loin pain. And another important clinical feature is they will have gross hematuria. And whenever these particular cysts are infected, yes, I am waiting for the name of the fascia surrounding the kidney. Anyone can answer this? And if these particular cysts are infected, the individual will have acute abdominal pain. Very good, Shubham. Okay, the individual will have acute abdominal pain. Okay, that is nothing but your fascia of Gerota. So this fascia of Gerota is being stretched, and that is the reason why the individual will have severe pain in the loin. So that will be the clinical features, right? So there will be loin pain, and the hematuria will be gross hematuria. Okay, and the blood pressure in these individuals, they are elevated. So, and in what group of individuals? In 75% of patients with polycystic kidney disease, the blood pressure is being elevated. Okay, around 75% of patients. Then why is that? That is because of the intrarenal ischemia causing the activation of RAS. Renal stone formation also will be there, that is seen in 15 to 20% of patients. And what type of renal stone will be this? It is the urate stone. And coming to renal cell carcinoma, so see, incidence of renal cell carcinoma increases when there is bilateral polycystic kidney disease. That means in both the kidneys, if there is formation of the cyst, the incidence of renal cell carcinoma is very high. And by the age of 60 years, they develop end-stage renal disease. By the age of 60 years, they develop end-stage renal disease. Then, what are the extrarenal manifestations? See, the cysts, they are not only present in the kidney, they are present even outside the kidney. What is the most common site outside the kidney where the cyst can be present? That is within the liver. The other sites will be spleen, pancreas, and ovaries. But the most common extrarenal site will be liver. And the other extrarenal manifestations will be berry aneurysms. So these berry aneurysms are nothing but these are the aneurysms originating from circle of villi. And if these aneurysms rupture, the individual will develop the subarachnoid hemorrhage. If these aneurysms rupture, the individual will develop subarachnoid hemorrhage. Then the another very important extrarenal abnormality will be colonic diverticulosis. Right, colonic diverticulosis. So this will be the GIT manifestation. Right, this will be the GIT manifestation. Then what will be the cardiovascular system manifestation? That will be in the form of mitral valve prolapse. That will be in the form of mitral valve prolapse. So these are the extrarenal manifestations. Okay. Then what is the first line investigation? First line investigation will be the ultrasound abdomen. Then what is the investigation of choice? That is CT abdomen. That is CT abdomen. Then how do you treat these patients? See, it is like symptomatic treatment. There is no particular drug which will completely reverse this polycystic kidney disease. So if the blood pressure is high, then you should reduce the blood pressure to less than 140/90, for which you can give the ACE inhibitors or angiotensin receptor blockers should be given. And if the cysts are being infected, so I said if the cysts are infected, the individual can have acute abdominal pain. So you should give antibiotics which are lipid soluble antibiotics. right, which are nothing but lipid soluble antibiotics. Okay, then if the individual lands up in stage 5 end stage renal disease, then you should do kidney transplantation, right? You should do kidney transplantation when the individual develops end stage renal disease. Then coming to the loin pain, so if there is development of the loin pain because of the enlargement of the fascia of Gerota, then you should do nephrectomy, right? You should do nephrectomy. So either you do partial or total nephrectomy. Then what are the drugs which will slow the progression of the disease, right? What are the drugs which will slow the progression of the disease? The drugs which will slow the progression of the disease will be sirolimus or the everolimus, right? The sirolimus or everolimus, these are the drugs which will slow the progression of the disease. So this completes quick recap of your polycystic kidney disease. Okay, right? So once we are done with the polycystic kidney disease, then let me just discuss this important clinical scenario. So the clinical scenario is a 68-year-old woman, poorly controlled diabetes, presents to accident and emergency with a 2-day history of severe pain in the right flank, nausea, fever, coming and going. On examination, patient appears unwell, sweaty, and visible rigors with temperature of 38 degrees centigrade. The patient denies any recent travel. Urine dipstick is positive for protein, blood, leukocytes, and nitrates. And a CT of the abdomen revealed gas in the renal parenchymal area. What is the most likely diagnosis in this patient? Yes, anyone can quickly answer this? Yes, the answer is it is not renal tuberculosis, it is the pyelonephritis. It is pyelonephritis. Okay. Now, why pyelonephritis? I'll tell you. See, pyelonephritis, it is potentially a life-threatening disease that most commonly occurs due to gram-negative infection. And what is the risk factor in this individual to develop pyelonephritis, that is infection of renal parenchyma? That is poorly controlled diabetes mellitus, right? Poorly controlled diabetes mellitus. Okay. That is the important risk factor. Now, another important point to tell you it is that pyelonephritis is that only when there is parenchymal infection, right? Only when there is parenchymal infection, only in parenchymal infection you have this gas accumulation which is identifiable on CT scan, right? Okay, only in pyelonephritis. And you take all these other 4 options, you don't have the gas in renal parenchyma. Okay, gas in renal parenchyma is not seen in renal stones, renal infarction, diabetic nephropathy, or renal tuberculosis. You come across this only in case of the pyelonephritis. Okay, so that is the reason why the answer is E, right? Then the other points which will rule out your renal tuberculosis is that is, see, these patients, like individual having the severe pain and the presence of blood in the urine analysis, that is unlikely in case of renal tuberculosis. Unlikely. I'm not saying that it will not be there. Unlikely in case of renal tuberculosis, but that can be there in patients with the pyelonephritis. Okay. So we are done with the polycystic kidney disease and as well as the infectious pathologies as well. Now, the next is, you want to use me thick pen? Okay. Right. Now, let me discuss quickly the hereditary diseases in the kidney. So, what are the hereditary diseases in the kidney? The hereditary diseases in the kidney are these 4: Bartter syndrome, Gitelman syndrome, Liddle's, and as well as the Alport syndrome. Okay. Now, what is very, very important for us to discuss here is these 2, Bartter's and as well as the Gitelman's. Okay. Because this Bartter's and Gitelman's, in both of them, it is autosomal recessive type of inheritance. Rachna, okay. So a quick question from Rachna. So she says like she got 138 in the GT. So usually the GTs which are being conducted by the institutes are in such a way that the questions will be quite difficult. Difficult questions are being set by many of the institutes under the impression that because the exam also will be very difficult. But if you take in the recent FMG exams, many of the recent past 2 to 3 exams, the questions were very easy. Those students who were getting the GTs around 130 and 140, they were easily able to get around 160 or 170 in the FMG exam conducted by NBE. So don't worry about if you are getting the GT score of around 130 or 140, because the questions which are being set up by the institutes or the online platforms, they are very difficult questions. Why is that? Under the expectation that even the NBE exam also will be difficult. But in the recent scenario, the questions are being very easy questions. Okay. Yes, Rachna, don't worry. Whatever it is, either it is Prep Ladder or some other XYZ platform, the questions are being set little difficult manner under the impression that because the NBE may give you difficult questions. But in the recent time, right? But in the recent time, the questions are being easy. Okay, right. Now, let me just quickly discuss the hereditary disorders, that is Bartter syndrome and as well as Gitelman syndrome. So both of them, the type of inheritance will be autosomal recessive type of inheritance. Then you take the pathophysiology. See, in Bartter syndrome, the pathophysiology will be at the loop of Henle, whereas in Gitelman syndrome, the pathology will be at the level of the distal convoluted tubule. And what is the age of presentation in Bartter syndrome? The age of presentation will be early in the life, whereas in Gitelman syndrome, it is late childhood or early adulthood. Then if you take the clinical features, in both of these patients, the presentation will be in the form of polyuria. And there is no hypertension. The blood pressure will be normal in both of these individuals. Normal in, then what is the difference in these individuals is, in patients with the Bartter syndrome, they will have this sensory neural hearing loss. But in case of Gitelman's, there is no sensory neural hearing loss. The other point of difference between these two is that in case of the Bartter syndrome, both of them, they will have hypokalemia. There is no difference in that. Both of them, they will have the hypokalemia. And you take the serum magnesium. So magnesium levels in Bartter syndrome, either it is normal or low. But whereas here in Gitelman syndrome, definitely the magnesium levels always it will be low. And another important difference is the urinary calcium excretion. So if you take the urinary calcium excretion will be elevated in Bartter's, but whereas the urinary calcium excretion will be reduced in Gitelman syndrome. So this is one important difference between the Bartter's and as well as Gitelman's. And next is the renal prostaglandin E2 levels, that is increased in Bartter's, whereas normal in case of the Gitelman syndrome. Then how will you treat Bartter syndrome? The drug of choice will be indomethacin. Why? Because you want to reduce the prostaglandin E2 levels. Whereas Gitelman syndrome, it is completely the symptomatic treatment. We don't have any specific drug which will reverse your Gitelman syndrome. And another important point that you have is that the Bartter syndrome, okay, so it will mimic the loop diuretics. Okay, Bartter syndrome, it will mimic the loop diuretics. Okay, so what it will do, it will inhibit the sodium potassium 2 chloride channels. That is what is your Bartter's. Whereas Gitelman syndrome, that will mimic, right, that will mimic the thiazide diuretics. I'm very sorry about this, right, this will mimic the thiazide diuretics. All right, next. And the another very important is what will happen in Gitelman's, there is inhibition of sodium chloride channels. Inhibition of the sodium chloride channels. Okay, so that is about your Bartter's and as well as the Gitelman syndrome. And in both of them, autosomal recessive, no hypertension, blood pressure will be absolutely normal. So how will you differentiate these two? That is urinary calcium levels. Urinary calcium levels are high in Bartter's, and in Gitelman's the urinary calcium levels are low. Okay, right. Now, coming to the next important forms of hereditary disorder, hypertension with hypokalemia. Where do you come across this? Hypertension with hypokalemia, where do you come across this? So hypertension with hypokalemia, you will come across this in patients with the Liddle syndrome. Liddle syndrome. Okay, that is Liddle syndrome. In Barter's, what did I tell you? Normal blood pressure. Gentleman's, what did I tell you? Normal blood pressure. So Liddle syndrome, the type of inheritance is autosomal dominant type of inheritance. And what is the problem in Liddle's? There is increase in the ENaC activity, epithelial sodium channel activity, right? Increased epithelial sodium channel activity. And because of which there will be hypertension in these individuals, there will be hypokalemia, right? I'm very sorry, intermittently the screen gets blurred. I'm very sorry for that. So there will be hypokalemia and there will be the hypernatremia, and there will be also acidosis. I'm sorry, there will be metabolic alkalosis. Okay, there will be metabolic alkalosis. Then what is the drug of choice in the Liddle syndrome? Drug of choice in Liddle syndrome is ENaC blocker. And what is that ENaC blocker? That is amiloride or even your triamterene. Even triamterene. Okay, so that is about your Liddle syndrome. So we are done with the Liddles. Okay, right. Then after that, you see another important hereditary disorder. Mutation in alpha 5 chain of type 4 collagen. What is the diagnosis? Yes, I'll be sending the PDF. I'll be sending the PDF on my Telegram channel. So please don't worry about it. Right. So, no. Jariwala, it is not Goodpasture syndrome, it is Alport syndrome. See, in Goodpasture syndrome, it is alpha 3 chain of type 4 collagen, whereas in Alport's, it is your alpha 5 chain of the type 4 collagen. So please remember, so Goodpasture's, how many letters you have? GPS, Goodpasture syndrome. So 3 letters are there. So just remember alpha 3 chain. So alpha 5 chain will be the Alport's. And in Alport's, you have a triad of manifestation. Why? Because this alpha 5 chain of type 4 collagen, you have this in the kidney, you have this in the ear, right? That is within the cochlea, and you also have this in the eye. So accordingly, you have the triad of manifestation in Alport's. So one is hereditary nephritis, and because of the hereditary nephritis, what will be the earliest presentation? The earliest presentation will be the hematuria, and other features also will be there. Proteinuria will be there, progressive renal insufficiency, and rarely nephrotic syndrome. And sensory neural hearing loss, this will be the most common extrarenal abnormality. And it is not symmetrical sensory neural hearing loss, it is asymmetrical sensory neural hearing loss. Then coming to the ocular abnormality. Ocular abnormality, that is in the form of anterior lenticonus. Okay, and this anterior lenticonus, it is there bilaterally. And because of this anterior lenticonus, there will be recurrent corneal erosions and as well as the corneal opacities. Okay. Right. See, those students who are unable to get my Telegram channel, you can text me on my WhatsApp number 9686 241 211. This is my WhatsApp number. So you can text me on this. I will send you the my Telegram channel link, and even I will also share on Unacademy Telegram channel as well. Okay, don't worry about the PDF. Right. Next, then so that is about your hereditary disorders. What is that? Gentlemen's, Barter's, then your Liddle's and Alport syndrome. We are done with the hereditary disorders. Then we will come on to the next important group of disorders. Yes, you see this. 10-year-old child develops hematuria after 2 days of diarrhea. Blood film shows fragmented RBC and thrombocytopenia. Ultrasound shows marked enlargement of both the kidneys. Right? And what is the likely diagnosis? Right? What is the likely diagnosis? Yes. Anyone want to make a quick attempt of this question? Yes. It is not hemolytic uremic syndrome. It is not your hemolytic uremic syndrome. So it is renal vein thrombosis. The answer is renal vein thrombosis. Why? Why it is not hemolytic uremic syndrome? Why it is renal vein thrombosis? So ultrasound shows marked enlargement of both the kidneys. So this point tells you it is renal vein thrombosis. Whereas in hemolytic uremic syndrome, you will have normal sized kidney. You will have normal sized kidney. So that marked enlargement of both the kidneys, that is the point which is going in favor of renal vein thrombosis. Okay, right. Now let me quickly recap the renal vein thrombosis. So in renal vein thrombosis, please remember there will be enlargement of the kidneys. Either it is unilateral or bilateral, depending upon where exactly you have renal vein thrombosis. But if there is bilateral renal vein thrombosis, you will have bilateral enlargement. That becomes little difficult for the diagnosis. And you take renal vein thrombosis or you take hemolytic uremic syndrome, both of them, they are preceded by the gastroenteritis. Both of them, they are preceded by gastroenteritis. So what will be the presentation? The presentation that will be in the form of dehydration. And in both of these individuals, there will be microangiopathic hemolytic anemia. So because of this, the individual will also have the pallor. The individual will also have thrombocytopenia, and the patient will also develop acute renal failure. The patient will also develop acute renal failure. And what is the most common cause of your renal vein thrombosis? Most common cause of renal vein thrombosis will be membranous glomerulonephritis. And is there any drug that will cause renal vein thrombosis? Yes. What is that particular drug? That particular drug will be the oral contraceptive pills. And is there any malignancy which will cause renal vein thrombosis? Yes. That will be your renal cell carcinoma. Then how will you diagnose this renal vein thrombosis? So Doppler flow study or angiography or IVC, right? Angiography of inferior vena cava, that will confirm the diagnosis of renal vein thrombosis, right? And what is the treatment in renal vein thrombosis? That is anticoagulant. And what type of acute renal failure that can be seen in renal vein thrombosis? That will be post-renal type of acute renal failure. Okay, so this is in nutshell about renal vein thrombosis. So what is a very important differentiating feature between renal vein thrombosis and hemolytic uremic syndrome? Renal vein thrombosis, there is marked enlargement of the kidneys, but in hemolytic uremic syndrome there will be normal sized kidneys. So that is about your renal vein thrombosis. Okay, then next you see the another important question. Yes, what do you think is the most common cause of renal artery stenosis in young adults in India? Yes, most common cause of renal artery stenosis in young adults in India. Pre-renal, it is due to decreased renal perfusion. Okay, you come across this in congestive heart failure, cirrhosis of liver. So that will be pre-renal. Okay, right. So young in India, so when we are using the word India, so just mark it as non-specific iotoarthritis. Non-specific iotoarthritis. Fibromuscular dysplasia, this is most common in the West. This is most common in the West, not in India. Okay, right. Now let us discuss in detail about the renal artery stenosis quickly in just 5 minutes. So renal artery stenosis, what is the most common cause of renal artery stenosis in young individuals in India? That is non-specific iotoarthritis, that is your Takayasu arthritis. Whereas in the West, the most common cause will be the fibromuscular dysplasia. Then what is the most common cause in elderly individuals? In elderly individuals, it is atherosclerosis, right? It is atherosclerosis. Okay, then coming to these patients with renal artery stenosis, what do they present with? They present with hypertension. Why is that? That is due to activation of renin-angiotensin aldosterone system. And this RAS, it contributes to 5% of patients with secondary hypertension. And this bilateral renal artery stenosis, it is present in almost 50% of patients. And when you do an abdominal examination, right, I will do PYQ sessions also. Tomorrow we will be doing PYQ sessions, so don't worry about that. So I will be doing these YouTube sessions for FMGE for another 2 days, even tomorrow and day after tomorrow as well. Okay, right. So abdominal examination, if you observe in renal artery stenosis, there will be renal bruit. Right, when you auscultate, there will be the renal bruit. And what is the screening procedure for renal artery stenosis? The screening procedure will be gadolinium enhanced, that will be gadolinium enhanced 3-dimensional magnetic resonance angiography. That will be your screening procedure. Then what is the confirmatory diagnosis? The confirmatory diagnosis will be contrast enhanced arteriography, right? Contrast enhanced arteriography, that will be the confirmatory test for your renal artery stenosis. And if it is unilateral renal artery stenosis, you can give the AC inhibitors or ARBs. But if it is bilateral renal artery stenosis, then AC inhibitors are contraindicated. If it is bilateral renal artery stenosis, the AC inhibitors are absolutely contraindicated. So if it is bilateral renal artery stenosis, what you have to do is PTRA, that is percutaneous transluminal renal angioplasty has to be done. Percutaneous transluminal renal angioplasty. Okay, right. Can you revise ABG analysis and ECG is also treatment according to the ECG? Yes, Rachna, I'll do that. Don't worry. Before your the FMGE exam, I'll revise ABG and I will revise even the important ECGs as well. Okay. Right. So that is about your renal vascular diseases, renal vein thrombosis and renal artery stenosis. So we are done with the nephrology aspect. We are done. We have discussed acute kidney injury, we have discussed chronic kidney injury, we have discussed renal replacement therapy, that is dialysis and renal transplantation. Then we have discussed nephrotic syndrome, all the conditions. We have discussed nephritic syndrome, all the conditions. Then we have discussed polycystic kidney disease. We have discussed the infectious pathologies, that is like pyelonephritis and all. Then we have discussed the hereditary disorders, Bartter syndrome, Gentleman syndrome, Liddle syndrome, and then Alport syndrome. Then we have discussed renal vascular disorders, that is renal vein thrombosis and renal artery stenosis. So, okay, so we are done with this, the nephrology. Right, so just give me a quick review of the nephrology session. How was it? Right, now we'll move on to the connective tissue disorders. Right, we'll move on to the connective tissue disorders. Okay, right, so if you take this connective tissue disorders, right, so thank you very much. So connective tissue disorders, if you see, like we'll discuss some clinical scenarios and I'll also quickly recap all the connective tissue disorders as well. Okay, right. So a 32-year-old woman with long-standing diagnosis of SLE is evaluated by her rheumatologist as routine follow-up. A new cardiac murmur is heard and an echocardiogram is ordered. She is feeling well and no fever, has no fever, no weight loss, and there is no pre-existing cardiac disease. 2D echo is being shown here. Which of the following statements is true in this question? Which of the following statement is true in this question? So I have given you the 2D echo picture also, and this is the abnormality what you are observing here. Can anyone tell me what is the diagnosis and what is the correct point? Yes. Just 1 minute. Yes. So the correct answer here is A. The correct answer here is A. Now, what exactly is this SLE? And what is that the points, the marker is towards the vegetations. Okay, whatever that your hyperechoic lesions that you are seeing, they are nothing but vegetations. So what the patient has developed? Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Okay, right? Now, in Liebman-Sachs endocarditis, the vegetations, how are these vegetations? They are the sterile vegetations. They are sterile vegetations. Okay, so blood cultures are unlikely to be positive because they are sterile vegetations, right? Now, when there is Liebman-Sachs endocarditis, glucocorticoid therapy will be of no use. Glucocorticoid therapy will be useful for pericarditis, not for endocarditis. So if it is endocarditis, then you have to do valvuloplasty. You have to do valvuloplasty. Okay, now pericarditis is frequently present concomitantly is a wrong statement. As such, pericarditis is the most common presentation in your SLE, but it is not present concomitantly. Okay, so that is the reason why your C is an incorrect statement. The lesion has low risk of embolization is a wrong statement. This lesion, it has the high risk of embolization. These vegetations, they can rupture, and once these vegetations rupture, they can embolize into the systemic circulation. Okay, so that is about your Liebman-Sachs endocarditis. So what is the first topic? We will be doing a quick revision now. The quick revision we will be doing about the SLE now. So in SLE, there are 11 important manifestations. Out of these 11 important manifestations, you should have 4 for the diagnosis. You should have 4 for the diagnosis. Okay, right. So this will be the diagnostic criteria for your SLE. Right. So this is a mnemonic. So what is that particular mnemonic? The mnemonic is that you wash your brain with soap, then you will get an MD seat. That is what is the mnemonic. So what is this? S stands for? S stands for the serositis, pleuritis and pericarditis. O stands for oral ulcers. A stands for arthritis. P stands for photosensitivity. B stands for blood disorders, that is in the form of pancytopenia. R stands for renal involvement. A stands for ANA will be positive. I stands for immunological criteria, that is anti-Smith and anti-dsDNA. N stands for neurological manifestations. M is malar rash. D is your discoid rash. Now I'll quickly recap the entire SLE in just 5 minutes. Okay, right. So these manifestations, I'll try to elaborate this. So if the question is asked, what is the most common presentation in SLE? Most common presentation in SLE will be in the form of fatigue. And what is the next most common manifestation followed by the fatigue? So along with this fatigue and fever, the next most manifestation will be the hematological manifestation, and that hematological manifestation will be in the form of pancytopenia, and they will have cutaneous manifestations, and these cutaneous manifestations will be in the form of the malar rash. So if the question is asked like what is the most common SLE rash, the most common SLE rash will be the malar rash. Most common SLE rash will be the malar rash. So how will be the malar rash? You see, this is what is your malar rash. Okay, this is what is your malar rash. So it is like fixed erythematous, either it is flat or even raised. They are present over the malar eminences. And other rash that will be there is the discoid rash. And arthritis will be there, that is non-erosive arthropathy. And this will be your photosensitivity, and this is your the oral ulcers. Okay, so these are the mucocutaneous manifestations in patients with the SLE. Okay, right. Then you see this quick question, right? In which of the following arthritis the erosions are not seen? In which of the following arthritis the erosions are not seen? So please remember, in patients with SLE, you don't have erosions. It is a non-erosive arthritis. Okay. And in SLE, what is the joint manifestation? Most common manifestation related to musculoskeletal system will be in the form of synovitis. Right, in the form of synovitis. Now, then we will take up the individual organs. So you take the kidney. So the kidney manifestations in the SLE, what do we call it as? The lupus nephritis. Now, if the question is asked, right? Now, if the question is asked, what is the most common lesion in the lupus nephritis? The most common lesion will be wire loop lesions. Wire loop lesions, and these wire loop lesions are present in which class of your lupus nephritis? They are present in class 4, which is nothing but diffuse lupus nephritis. And what will be the cardiac manifestation in SLE? The cardiac manifestation in SLE will be in the form of pancarditis. And which is most common among all these? Most common will be the pericarditis. Okay, then what will be the lung involvement? Lung involvement in patients with the systemic lupus erythematosus will be in the form of the pleural effusion. What type of pleural effusion? That is exudative type of the pleural effusion. That is what you will have. Apart from this pleural effusion, the individual will also develop pleuritis, where the individual will have pleuritic type of chest pain, and you have a classical syndrome. And what is that syndrome? That is shrinking lung syndrome. But this shrinking lung syndrome, it is not the common manifestation in SLE. It is the rare manifestation that you will have in SLE. That is shrinking lung syndrome. And why do you get this shrinking lung syndrome? That is due to diaphragmatic myopathy. So due to antibody formation against the diaphragm, there will be diaphragmatic paralysis and there will be elevation of dome of diaphragm. The lung will be compressed. So that is what is called as the shrinking lung syndrome. This is one of the rare manifestation. And in some cases, there can be also development of the interstitial lung disease. And what will be the CNS manifestations in patients with the SLE? The CNS manifestations will be in the form of the seizures. And what will be the psychiatric manifestation? That will be in the form of psychosis. And what will be... No. It is not class 3. The wire loop lesions... Okay, you see this question. Wire loop lesions, they are often characteristic for which class of lupus nephritis? Wire loop lesions are classical for diffuse lupus nephritis. Where is the reference? Reference is Harrison, 21st edition. You can go through that. Okay, so it is class 4, not class 3. Right? There is no doubt in that. Okay, right. Now, then what will be the hematological manifestation? The hematological manifestation will be in the form of pancytopenia, right? And there will be autoimmune hemolytic anemia. So because it's an autoimmune hemolytic anemia, what type of your hemolytic anemia is this? It is Coombs positive hemolytic anemia. Right, that will be Coombs positive hemolytic anemia and Apla syndrome, which is nothing but hypercoagulability. And because of Apla syndrome, the presentation will be in the form of recurrent abortions. And this Apla syndrome, it is seen in almost 50% of patients. It is seen in almost, right, if some other educator tells class 3, I'm not concerned about that. In my class, remember, it is class 4 and I'm giving you the reference also, that is Harrison 21st edition, right? So I don't want to comment about the other educators here. Okay, right. So recurrent abortions, like that will be the presentation in case of the Apla syndrome. Then coming to drug-induced lupus. So if the question is asked, what is the most common drug? Most common drug that will be causing drug-induced lupus will be the procainamide. What is procainamide? It is class 1 anti-arrhythmic drug. It is class 1 anti-arrhythmic drug. Okay, right. So this is about the quick recap of the entire SLE. Now, what are the other important things that you need to know in the SLE is the antibodies. So if you take these antibodies, right, so right. So you take the most sensitive marker for your SLE. Most sensitive marker for SLE will be anti-nuclear antibody. And what is the most specific? Most specific will be anti-Smith. And what about your anti-dsDNA? Anti-dsDNA, it tells you about the severity of the disease. It tells you about the severity of the disease. And what is the marker for drug-induced SLE? The marker for drug-induced SLE will be anti-histone antibody. And what is the antibody that is responsible for thrombus formation and recurrent abortion? That is your APLA, antiphospholipid antibody. I will tell you the antibodies in APLA. And what is the antibody that is responsible for psychosis in SLE? That will be anti-ribosomal P. Right, anti-ribosomal P. And what is the antibody that is responsible for photosensitivity in your SLE? That is your anti-Rho or SSA antibody. And what is the antibody which is responsible for CNS lupus? That will be your anti-neuronal antibody, right? Anti-neuronal antibody or anti-glutamate antibody. Right, anti-glutamate antibody. Okay, so that is about the markers, the antibodies in SLE. Now, quick important thing that we need to discuss in SLE is about the treatment. So, what is the drug of choice for acute episodes of SLE? The drug of choice for acute episodes of SLE will be the methylprednisolone, right? That is methylprednisolone. And if the individual develops Liebman-Sachs endocarditis, there is no role of steroids here. So what you have to do here, you have to do valvuloplasty. And when there is development of Apla syndrome, in this case, you should give aspirin along with that anticoagulant. Either heparin or warfarin should be given. And if there is development of photosensitivity in patients with SLE, you need to give hydroxychloroquine. And if there is lupus nephritis with end-stage renal disease, then you should do renal transplantation, right? Renal transplantation. And if there is development of, what is the drug of choice for severe lupus nephritis? That will be cyclophosphamide. And if there is development of psychosis, the drug that we give for psychosis will be haloperidol. Then what is the drug of choice for SLE exacerbation in pregnancy? That will be your hydroxychloroquine, and you should give steroids if necessary. And if there is development of the lupus cerebritis, then you should give dexamethasone. Okay, so this is about quick recap of your SLE. We are done with the topic of SLE. Then we will move on to the next important topic, that is the ankylosing spondylitis. So in ankylosing spondylitis, you should remember two things. Okay, what is that? That there is involvement of the spine and that there is involvement of the sacroiliac joint. Okay, now what will be the spine involvement? There will be fused vertebra, right? That will be fused vertebra. And because of the sacroiliac joint involvement, what will be the presentation of the patient? Presentation of the patient will be, they will have 3 months of low backache. Can anyone tell me what is the HLA in ankylosing spondylitis? What is the HLA in ankylosing spondylitis? So these patients, they present with low backache. That will be low backache. That will be there for nearly around 3 months. Okay. Now, so this low backache is mainly due to what? That is because of your sacroiliitis. So along with this sacroiliitis, there should be more than one spondyloarthropathy features. Okay, or yes, very good. That is your HLA-B27. Or if the individual is having HLA-B27 being positive, along with HLA-B27 positive, there should be more than or equal to 2 spondyloarthropathy features. More than or equal to 2 spondyloarthropathy features. So that is about your ankylosing spondylitis. Now, what is that spondyloarthropathy features? I said you, if sacroiliitis is there, along with that more than one spondyloarthropathy features. And if HLA-B27 is there, more than 2 spondyloarthropathy features should be there. Now, what is that spondyloarthropathy features? The mnemonic is A, B, C, D, F, G, I, P. What is this? A stands for? That is arthritis. And what does this B stands for? That will be HLA-B27 being positive. What does this C stands for? The C-reactive protein will be positive. And what does this D stands for? That will be dactylitis. What does E stands for? That will be enthesitis. What does this F stands for? There should be family history of the spondyloarthropathies. G stands for there should be a good response to your NSAIDs. I stands for there will be inflammatory back pain. Right, there will be inflammatory back pain. And P stands for the skin manifestation, that will be in the form of psoriasis. So if there is sacroiliitis, along with sacroiliitis, more than one spondyloarthropathy feature should be there. And if it is HLA-B27, more than or equal to 2 spondyloarthropathy features should be there, to call it as ankylosing spondylitis. And in ankylosing spondylitis, you also have extra-articular manifestation. And what is the most common extra-articular manifestation? That will be in the form of the uveitis. Okay, and what are the others? Lung involvement will be there in the form of upper lobe fibrosis, that will result in restrictive lung disease, and cardiac involvement will be there, that is in the form of aortic regurgitation, ischemic heart disease, and there can be also development of the AV block, third degree AV block. And inflammatory bowel disease is another important associated feature. Cauda equina syndrome, that is your compression of your cauda, that is spine, and psoriasis. So these are the extra-articular manifestations in patients with the ankylosing spondylitis. Okay. Now, in order to assess the spine, you will be doing a test. Yes. What is this? Schober's test or Schober's sign is used to evaluate. Schober's sign is used to evaluate. What is this? Schober's sign is used to evaluate. Please remember this. It is used to evaluate the flexion of the lumbar spine. It is used to evaluate the flexion of the lumbar spine. Now, in ankylosing spondylitis, what is very, very important is the imaging. So, you have this classical bamboo spine, right? And what will be the spinal involvement? The spinal involvement from low to up. That is from the lower part of the spine. That is at the level of the sacrum, the spinal involvement starts, and then gradually it goes upwards. Okay, right. Then followed by that, the another important, this is a very, very important asked question, very repeatedly asked, that is the presence of dagger sign. So where do you get this dagger sign? That is in patients with the ankylosing spondylitis. And why do you get this dagger sign? That is due to ossification of supraspinous and as well as the interspinous ligaments. That will result in dagger sign. And then when you take the x-ray of the sacroiliac joint, the sacroiliac joint is completely destroyed. Sacroiliac joint is completely destroyed. Then how do you treat this ankylosing spondylitis? So what is the first line drug for ankylosing spondylitis? That will be NSAIDs. The first line treatment will be NSAIDs. And in those individuals who are like NSAID resistant, right? In those individuals who are like NSAID resistant, in them you should give the TNF inhibitors. Okay, in them you should give TNF inhibitors. Then we have the new molecules, that is interleukin 17A inhibitors. What are these interleukin 17A inhibitors? That includes secukinumab, okay, and the other one is ixekizumab, right? So these are the interleukin 17A inhibitors. Okay, so we are done with the ankylosing spondylitis, right? Then, so now I was telling you about the recurrent abortions in Apla syndrome. What was the cause for recurrent abortions in case of the Apla syndrome? That is the hypercoagulability. And why is that particular hypercoagulability? Yes, Manjeet, my WhatsApp number is 9686 241 211. Okay, so you can text me on this number. I will send you my Telegram link if you are unable to get my Telegram link. Okay, right. Now, so this Apla syndrome, that recurrent abortions are mainly because of the hypercoagulability. What is another name for Apla syndrome? Can anyone tell me? Right. So lab criteria, that is anti-cardiolipin antibody, that is IgG or IgM will be positive. Anti-beta-2 glycoprotein 1 will be positive, and lupus anticoagulant will be positive. And you know which particular antibody is having the highest tendency to cause that recurrent abortions? That is your lupus anticoagulant. The presence of lupus anticoagulant tells you that the individual is at high risk of development of the recurrent abortions. Okay, that is a lab criteria, right? So what is the name of this criteria? That is Saparo criteria. So the clinical criteria will be vascular thrombosis and as well as the abortions, right? And then abortions. Okay, so another name for this, the Apla syndrome, is, this is also called as HUGHES syndrome. So you can call it as Hughes syndrome or the Hug syndrome, right? So this is about your Apla syndrome, and these patients, they require aspirin and as well as the anticoagulants, right? Then the next important discussion is about the rheumatoid arthritis. Okay, so rheumatoid arthritis, as we are very much aware, it is the small joints which are being affected. And what is that small joints which are being affected in rheumatoid arthritis? That is metacarpophalangeal joints and as well as the proximal interphalangeal joints. And distal interphalangeal joints are not affected in case of rheumatoid arthritis. And even in the lower limb, there is also involvement of MTP, that is metatarsophalangeal joint, is also affected. Okay, then, and in long-standing cases of rheumatoid arthritis, there is development of the deformities. So what will be the deformities in the long-standing cases of rheumatoid arthritis? So one is your Swan-neck deformity, where there is hyperextension of proximal interphalangeal joint and there will be flexion of the distal interphalangeal joint. And the other one is the Bottomley's deformity. So it is exactly opposite. So in the proximal interphalangeal joint, you will have flexion, and in distal interphalangeal joint, right, in the DIP, you have extension. Okay, so these two important things you should know, that is Swan-neck deformity and Bottomley's deformity. The other one is Z-shaped thumb, and another important deformity will be your ulnar deviation. Now, what is a very, very important differential diagnosis for Swan-neck deformity? Very important differential diagnosis will be mallet finger deformity. So this mallet finger deformity, it is not seen in case of rheumatoid arthritis. So in mallet finger deformity, you will have only flexion of the distal interphalangeal joint, whereas the proximal interphalangeal joint, it will be absolutely normal. And where do you get this mallet finger deformity? You will get this whenever there is rupture of the tendon which is getting attached to the distal digit. And which particular tendon? It should be the extensor tendon which is attaching to the distal digit, and if that is ruptured, then the individual will develop this mallet finger deformity. Now, in case of the rheumatoid arthritis, is there development of spine? Yes. Yeah, yes, Shilpa, I'll send you the PDF immediately after the class. Don't worry about it. So the spine involvement will be there. That is atlantoaxial dislocation will be there. So that is C1 and C2 joint dislocation will be there. And because of this atlantoaxial joint dislocation, the patient can present with quadriparesis. Okay, the patient will present with quadriparesis. And what type of quadriparesis will be? It is spastic quadriparesis. Spastic quadriparesis, because there is involvement of corticospinal tract, and because of this atlantoaxial joint dislocation, this particular dens, it can compress the respiratory centers within the medulla oblongata, and thereby the individual can also develop respiratory arrest. Right, thereby the individual can also develop respiratory arrest. So that is about your atlantoaxial dislocation that can be seen in patients with the rheumatoid arthritis. Okay, right. Then you take the extra articular manifestations in rheumatoid arthritis. See, all these connective tissue disorders, they are multi-system disorders because connective tissues are present in multiple systems. So these are all the extra articular manifestations in patients with the rheumatoid arthritis. Now, if the question is asked, what is the most common extra articular manifestation? The most common extra articular manifestation will be the subcutaneous nodules. And these subcutaneous nodules, where are they present? They are present on the extensor aspect of the forearm. They are present on the extensor aspect of the forearm. And these subcutaneous nodules, please remember, they are painless. They are painless. Then what is the cause of death in patients with rheumatoid arthritis? The cause of death is due to premature atherosclerosis of coronary arteries. So coronary artery disease causing MI, that would be the cause of death in patients with the rheumatoid arthritis. Okay. Why is that? That is due to premature atherosclerosis. Now you take this quick question. A 45-year-old coal mine, right? A 45-year-old coal mine worker presents with the cutaneous nodules, joint pain, and occasional cough with dyspnea. His chest radiograph shows multiple small 1 to 4 centimeters nodule in bilateral lung fields. Some of the nodules, they show cavitation and specks of calcification. So most likely these features are diagnostic of anyone? Right, very good, Abhishek Nath. So this is nothing but Kaplan syndrome. So what is this Kaplan syndrome? Rheumatoid arthritis plus coal workers pneumoconiosis. That is what is called as Kaplan syndrome. Then you should also know the Feltis syndrome. So what is this Feltis syndrome? You will have rheumatoid arthritis. There will be also neutropenia. Right, neutropenia. Yes. Now who will tell me what is the third component of the Feltis syndrome? What is the third component of the Feltis syndrome? Any one of you? Right. So, yes. So, rheumatoid arthritis, neutropenia, and splenomegaly. Okay, splenomegaly. Okay, so that will be the Feltis syndrome that you will come across in patients with rheumatoid arthritis. Then, what is the investigation of choice in rheumatoid arthritis? The investigation of choice will be anti-CCP, anti-cyclic citrullinated polypeptide. That is the investigation of choice. But you take RA factor, it is non-specific. Right, RA factor is non-specific because it is present in many conditions. Then you should know the chest x-ray. Sorry, you should know the x-ray of this particular digits which are affected in rheumatoid arthritis. So what is the classical presentation? You will have periarticular osteopenia. Right, you will have periarticular osteopenia. Okay, and next important thing is you need to do synovial fluid analysis. So when you do a synovial fluid analysis, you will have the presence of the inflammatory cells, and that inflammatory cells will be nearly around 5,000 to 50,000 cells will be there per cubic millimeter. 5,000 to 50,000 cells will be there per cubic millimeter. Then Coming to the treatment, what is the drug of choice in case of your rheumatoid arthritis? That is methotrexate. Methotrexate is considered as the drug of choice. And if the patient is not responding to methotrexate, then we give triple therapy. What is this triple therapy? Methotrexate, then hydroxychloroquine, then along with this we also give sulfa drug. Okay, this will be triple therapy. And even with the triple therapy, if the patient does not respond, then we start with the biological DMARDs. So this is about your rheumatoid arthritis in quick recap manner. Okay, then next, another important connective tissue disorder is the Ritter syndrome, which is also called reactive arthritis. Okay, so now this Ritter syndrome or reactive arthritis, this is characterized by a triad. So three important manifestations, that is arthritis, and that too the joints of the lower limbs are commonly affected. And these patients, they also have enthesitis. What is enthesitis? Where there is inflammation of the tendon at the point of insertion over the joint or insertion over the bone. That is called enthesitis. And these individuals, they also have reproductive organ manifestations, that is urethritis or cervicitis, and they will be also conjunctivitis. So this is what is a triad in Ritter's or reactive arthritis. Now in Ritter's, can anyone tell me what is the HLA association? Yes, what will be the HLA association in Ritter's or reactive arthritis? Any one of you? The HLA association in Ritter's or reactive arthritis. Quickly. Yes. So the HLA association in Ritter's or reactive arthritis will be, very good Rachna, so that will be HLA B27. That will be HLA B27. So now what are all the conditions where you have this HLA B27? Just remember this mnemonic. And what is that mnemonic? That particular mnemonic is pair. Okay, so what does this pair stands for? P stands for psoriatic arthritis, A stands for ankylosing spondylitis, I stands for inflammatory bowel disease, R stands for Ritter syndrome or the reactive arthritis. Ritter syndrome or reactive arthritis. Okay? Now you should know like what will be the dermatological manifestations. So dermatological manifestations in these individuals, there it is called as keratoderma blennorrhagica. Keratoderma blennorrhagica. So keratoderma blennorrhagica, it is nothing but hyperkeratotic vesicles. Hyperkeratotic vesicles over the palm and as well as sole. That will be your keratoderma blennorrhagica. Now in these individuals, there is also cardiac involvement, and that cardiac involvement in the form of aortic regurgitation. And even there can be complete heart block, but this will be rare manifestation in patients with Ritter's or reactive arthritis. So these are the features in case of Ritter's or reactive arthritis, but this particular triad is very important. Okay, now this Ritter's or reactive arthritis, it occurs secondary to gastrointestinal infection or it occurs secondary to sexually transmitted infection. Secondary to sexually transmitted infection will be chlamydia trachomatis. Secondary to gastrointestinal infection will be Shigella salmonella. Right, Shigella salmonella. Okay, but sexually transmitted infection, chlamydia trachomatis. Okay, then you should know the treatment accordingly. So how will you diagnose? The diagnosis is by culture. So what is the culture you have to do? You have to take the culture of urethra, or you have to take the culture of the cervix. Okay, and you can also take the culture of the urine and as well as the stool samples. Why is that stool samples? Because it can also occur secondary to gastroenteritis, that is Shigella salmonella and Campylobacter jejuni. And urine culture you have to take in order to look for what is the infective pathology causing urethritis. Then arthrocentesis. Why you have to do this arthrocentesis? In order to look for the inflammatory cells. Because there is asymmetrical arthritis of the lower limbs. Then HLA, it is HLA B27. Then coming to the treatment. So if you see the treatment, this non-specific urethritis, you can give the tetracycline group of antibiotics. And for arthritis, you need to give NSAIDs, non-steroidal anti-inflammatory drugs. And in those individuals who are not responding to the NSAIDs, in them, we give steroids, right? Or you give the sulfasalazine should be given. And if there is iritis, you should give local steroids. Okay, if there is iritis, you should give the local steroids. Okay, so that is about your treatment of Ritter's or reactive arthritis. So we are done with the Ritter's or reactive arthritis. Okay, right. Then, yes, please answer this question. We'll move on to the Sjogren syndrome next. Right, we'll move on to the discussion of the Sjogren syndrome. Sika syndrome is associated with all except Sika syndrome is associated with all except no, it is not scleroderma. It is the midline granuloma. It is midline granuloma. It can be associated even with rheumatoid arthritis. It can be associated even with chronic active hepatitis, but not with midline granuloma. What is the story? I'll tell you. Okay, right. Now, you take the Sjogren syndrome, you have the glandular manifestations. So what will be the glandular manifestations? That is, they will have dry eyes and they'll have dry mouth. Why is that? Because of the autoimmune, because of autoimmune destruction of lacrimal gland and autoimmune destruction of the salivary gland. They will have dry eyes and as well as dry mouth. And viral infection that is associated with the Sjogren syndrome is the HCV. Okay, the viral infection associated with Sjogren syndrome will be HCV. And if the question is asked, please remember, in Sjogren syndrome, you will not only have glandular, you also have extraglandular manifestation. And what is the most common extraglandular manifestation? Most common extraglandular manifestation will be in the form of arthritis. Okay, now we have two forms of Sjogren's, primary Sjogren's and secondary Sjogren's. What is primary Sjogren's? Primary Sjogren's means if it is only Sjogren syndrome, if it is only Sjogren syndrome, that is your primary Sjogren's. Then what is secondary Sjogren's? Secondary Sjogren's means it is associated with other connective tissue disorders also. Right, it is associated with other connective tissue disorders also. That is what is called the secondary Sjogren's. And what is that most common associated connective tissue disorder in secondary Sjogren's? That will be rheumatoid arthritis. Okay, so secondary Sjogren's, it can be associated with rheumatoid arthritis, it can be associated with your scleroderma, right? Okay, then coming to your Hereford syndrome, or which is also called uveitis. You come across this in patients with sarcoidosis. And this uveitis, it is a close differential diagnosis for Sjogren syndrome, right? Then what will happen in your Hereford syndrome? There also you will have dry eyes and dry mouth. But in case of Hereford syndrome, it is not autoimmune destruction of the gland. It is accumulation of non-caseating granuloma within the salivary gland and as well as the lacrimal gland in Hereford syndrome, non-caseating granuloma. Okay. Now, what are the antibodies in Sjogren's? So antibodies in Sjogren's will be SSA and as well as the SSB. What is the investigation of choice? Investigation of choice will be biopsy. So what will the biopsy show? The biopsy will show you the presence of CD4 plus T lymphocytes. The presence of CD4 plus T lymphocytes. Then what will happen to your salivary secretion? The salivary secretion will be decreased. How much is the normal flow rate of saliva? Normal flow rate of saliva will be around 1 to 2 ml per minute. 1 to 2 ml per minute. So in these individuals, the salivary secretion will be reduced. The salivary secretion will be reduced. And how much it will be? So it will be less than 1.5 ml in 15 minutes. That will be the salivary secretion in Sjogren syndrome. Then coming to the Schimmer's test. Schimmer's test is mainly to test the tear secretion. So what we will do, here we will place a litmus paper. We will place a litmus paper. So when will you consider that there is a normal tear secretion? Okay, you place this litmus paper for 5 minutes. And if the litmus paper, if it is blotted for up to 20 centimeters, if the litmus paper is blotted up to 20 centimeters, then it is considered to be normal tear secretion. But if the litmus paper is blotted less than 10 centimeters, then we consider it as insufficient tear production. Okay, so how will you test the tear production? That is by your Schimmer's test. Okay, then coming to the treatment. So if you see the treatment in these individuals, one is your eye care. So how will you give the eye care? Because the individual is having dry eyes because of decreased tear production. So you should give the artificial tears. You should give artificial tears. And it is immune mediated disorder. So you should give an immunosuppressive drug. And what is that immunosuppressive drug you will be giving? That is cyclosporin. So the cyclosporin will cause the immune suppression. Now, see, I said you, what is the most common extraglandular manifestation? That is arthritis. So for arthritis, what do we give? That will be NSAIDs, non-steroidal anti-inflammatory drugs. Okay. Then if there is the severe complications, right? If there is severe complications, then we give immunosuppressive agents. What will be that immunosuppressive agents? That immunosuppressive agents will be steroids, or you can also give intravenous immunoglobulins, right? And I said you there can be extra glandular manifestations. That means systemic involvement can also be there. If there is systemic involvement, then we give the drugs which will attack the B cells. What is that? We give rituximab and as well as belimumab. Okay, rituximab and as well as the belimumab. Okay, so that is about your Sjogren's syndrome. In nutshell, the entire story related to Sjogren's. Okay, right. Now, after having discussed about the Sjogren's, next another important connective tissue disorder that you need to know is the scleroderma. Okay, the another important thing is scleroderma. So what happens in scleroderma? In scleroderma, you have the abnormal or excessive accumulation of the fibrous tissue in the various parts of the body, and accordingly you have the two forms of scleroderma, localized and as well as the diffuse scleroderma. So if you take the localized scleroderma, where there is limited, right, where there is limited skin involvement, the skin involvement is confined only to the fingers, the skin involvement is confined only to the forearms, the skin the skin involvement is confined only to the face. Okay, and the visual organ involvement also will be there in localized. That visual organ involvement will be slow. Okay, so there will be slow progression of the visual involvement, and visual organ involvement also will be very late, and accordingly they develop this what is called CREST syndrome. So CREST syndrome, what does it stands for? There will be calcinosis, where there will be subcutaneous calcification of the fingers and extensor surface of the forearms. R stands for Raynaud's, right, where the individual will have pale color initially of the digits, there will be cyanosis next, and there will be redness later. So this sequence is very important: pale, cyanosis, blue color, then red. Then E stands for the esophageal dysmotility, right? E stands for esophageal dysmotility. Then S stands for sclerodactyly, where there is skin thickening which is limited to the fingers. Okay. Then T stands for telangiectasia. Right, T stands for telangiectasia, where there will be dilated capillaries. Where there will be dilated capillaries. Now you should know what are the drugs that will be causing this particular scleroderma. Very important drug, please remember, it is bleomycin. And we also have some aromatic hydrocarbons. Okay, then what is diffuse scleroderma? Then diffuse scleroderma is that where there is widespread skin involvement, right, where there is widespread skin involvement and there is rapid progression of the disease, and even the visual organ involvement, there will be early visual organ involvement. Whereas in case of limited, what did we discuss? There will be late visual organ involvement, whereas in diffused there is early visual organ involvement. Okay? Now let me quickly tell you about the diffuse scleroderma. So diffuse scleroderma, what did I tell you? The skin involvement will be there, and that too like diffuse skin involvement. So the skin involvement will start all the way from the fingers, and you see this is how the fingers will be in patients with scleroderma, right? So there will be like digital infarcts, and you can see the skin of these individuals like you have a puckered skin surrounding the mouth, right? So this is what will result in what is called microstomia, where the individual is unable to open the mouth, okay, right? So that will be the skin involvement. Raynaud's phenomenon. So already I taught you the Raynaud's phenomenon. So how will be the first? That is, whenever the individual fingers are exposed to cold, there will be pale color. That is due to abnormal vasoconstriction. Then there will be blue color. Why is that? That is due to increase in the levels of deoxygenated hemoglobin more than 4 to 5 milligrams percentage. Then there will be red color. Why is that red color? That is due to abnormal vasodilatation. That is what is your Raynaud's phenomenon. Then GAT manifestations, that will be in the form of dysphagia. Why is that they will have dysphagia? because the gastrointestinal motility is reduced and the fibrous tissue also gets accumulated in the lower esophageal sphincter. So movement of the food in the lower part of the GAT does not occur. That will result in the dysphagia. And not only dysphagia, these individuals, they also develop pneumatosis intestinalis. Right, pneumatosis intestinalis. What is pneumatosis intestinalis? The entire intestine, it is completely fibrous, so absorption of the food material does not occur. So this food, it undergoes fermentation by the gut bacteria. Because of the fermentation by the gut bacteria, there will be excessive gaseous accumulation within the GAT that will result in pneumatosis intestinalis, and because of which the patient can have the abdominal pain. And the other important feature is GERD, because there is failure of lower esophageal sphincter relaxation. So when the lower esophageal sphincter relaxation does not occur, there will be regurgitation of the food. Why is that lower esophageal sphincter not relaxing? That is because of the fibrous tissue accumulation within the lower esophageal sphincter. Musculoskeletal system involvement will be there, and this musculoskeletal system involvement will be in the form of arthritis. And this arthritis will be symmetrical arthritis. Please remember this. Symmetrical arthritis will be there. Then kidney involvement. So kidney involvement will be in the form of renal artery stenosis, and we call it as scleroderma renal crisis. And because of this renal artery stenosis, the individual will develop hypertensive crisis. There can be malignant hypertension. And for this scleroderma renal crisis, what is the drug of choice? The drug of choice will be the ACE inhibitors. Lung involvement will be there in the form of diffuse scleroderma, and that is in the form of interstitial fibrosis of the lung. Right, interstitial fibrosis of the lung. And there can be also, because of this interstitial fibrosis, there will be also development of pulmonary hypertension. What is the cardiac involvement? Cardiac involvement will be in the form of the cardiomyopathies. And what cardiomyopathy? Restrictive cardiomyopathy. And there can be also development of pericarditis and as well as the pericardial effusion. Then what will be the most common cause of death in patients with the scleroderma will be pulmonary hypertension. Why is this pulmonary hypertension? That is because of the lung involvement. Okay, right. Now what is the drug of choice in these patients with the, okay, before that you should know how to diagnose. So if you take the localized scleroderma, you should know the antibodies. What is the antibody in case of the localized scleroderma? That will be anti-centromere antibody. Whereas in diffuse scleroderma, what will be the antibody? The antibody here will be anti-topoisomerase. Anti-topoisomerase. Okay, that will be the antibody in case of the diffuse scleroderma, right? Or the another important antibody will be anti-SCL70. So these are the antibodies that will be helpful for diagnosing the scleroderma. Then treatment. What is the drug of choice in these patients with scleroderma? Drug of choice is steroids, because this fibrous tissue accumulation is due to abnormal immune reactivity. So you give steroids, that abnormal immune reactivity will get suppressed. So that is considered as drug of choice. Then there is GERD in these individuals. Okay, there is esophageal reflux is there. So how do you treat this esophageal reflux? You should give the proton pump inhibitors. You should give proton pump inhibitors. And because of the accumulation of the fibrous tissue within the intestines, there is decreased gastrointestinal motility. So for that, you should give a prokinetic agent. And this particular prokinetic agent, that includes metoclopramide. Okay, so we have cisapride. Right, we have cisapride and as well as the mozapride. Then hypertensive crisis. So how will you treat this hypertensive crisis? Like we give the ACE inhibitors, and this hypertensive crisis is due to what? That is due to scleroderma renal crisis. That is due to scleroderma renal crisis. And the other drug that can be given is the IV levetolol. Right, IV levetolol. Okay, then what is the cause of death? We have discussed pulmonary hypertension. So how will you treat this pulmonary hypertension? So treatment with pulmonary hypertension is that you can give the phosphodiesterase inhibitors. What are these phosphodiesterase inhibitors? That is sildenafil, then you have tadalafil, and you also have vardenafil. So sildenafil, tadalafil and vardenafil, these are the phosphodiesterase inhibitors. Okay, then we also have bosentan. What is this bosentan? Bosentan is, right, this bosentan is endothelin receptor antagonist. That is what is your bosentan. Okay, that is also given in the treatment of pulmonary hypertension. And then we also have, right, we also have the new drugs. And what is the new drug for your pulmonary hypertension? That is Riosigot. Okay, Riosigot. This Riosigot is what it is: guanylate cyclase stimulant. It is a guanylase or guanylate cyclase stimulant. So that is about the treatment for your pulmonary hypertension. Okay, but there are some refractory conditions. In spite of giving this endothelin receptor antagonist like bosentan, or in spite of giving this phosphodiesterase inhibitors like sildenafil or tadalafil or vardenafil, or in spite of giving this new drug Riosigat, there can be refractory hypertension. Then how will you treat this refractory hypertension? Refractory hypertension you have to treat with prostacyclin analogs, right? Prostacyclin analog. Okay, and what will be that prostacyclin agonist? That will be epoprostenol. Okay, and treprostenol, then iloprost. This iloprost, please remember, this has been asked one time, what is the route of administration? That is inhalational route of administration. Okay, so these are the drugs what we give for refractory pulmonary hypertension. So that is about your scleroderma in nutshell, right? Then yes, now you see this question. You are seeing Mr. Hensley. He is a 72-year-old man with only a history of hypertension on the hydrochlorothiazide. Okay, history of hypertension on hydrochlorothiazide, and he presents today with acute excruciating knee pain. On examination, his knee is warm, mildly erythematous, swollen, and tender to touch or passive movement. So, microscopic examination of the fluid is given, that is synovial fluid is given. Now tell me, Mr. Hensley, most likely metabolic derangement is? Yes, anyone? No, very good, Abhishek Nath. So it is gout. It is gout. Mr. Ainsley is suffering with what is called as gout. Okay. Now, what is gout? It is the scenario where there is increase in uric acid accumulation. That is due to increased uric acid production or decreased uric acid excretion. Understood? Now, what are the risk factors for the gout in this patient? Yes. What are the risk factors for the gout in this patient? Yes, any one of you quickly. First and foremost, Mr. Hensley, that is male. They are at increased risk. Then Mr. Hensley is taking hydrochlorothiazide. So thiazides, they are the risk factors. Mr. Hensley is having hypertension. That itself is also the risk factor. Okay, so now if you take this gout or gouty arthritis, so if you take this gout or gouty arthritis, what is the investigation of choice? Please remember, it is not serum uric acid. Investigation of choice is the synovial fluid analysis. And what will the synovial fluid analysis will show in gout or gouty arthritis? You will have needle shaped birefringent crystals. Now, one quick question here is the serum uric acid. Now tell me, in patients with your gout or gouty arthritis, the serum uric acid, can it be normal? In your gout or gouty arthritis, the serum uric acid, can it be normal? Yes. Can you have a normal serum uric acid in your gout or gouty arthritis? The answer is yes, you can have that. When will you have this? When can the serum uric acid levels may be normal? So during acute attacks, right, during acute attacks, the uric acid will go and accumulate within the joint. The uric acid will go and accumulate within the joint. So the entire uric acid has entered into the joint now. Within the joint, you have the presence of the needle shaped crystals. So during this point, you can have normal serum uric acid levels. That can happen. That can happen. Okay, right. So that is the reason why investigation of choice is not serum uric acid. Investigation of choice is synovial fluid analysis. Then quickly, if you take the treatment for gout or gouty arthritis, you should know the drugs what are given for acute attack. You should know the drugs which are given for chronic attack of gout. For acute attack of gout, either we give NSAIDs, and if the patient is not responding, we give colchicine, and if the patient is not responding, we also give steroids in acute attack. Then what is the treatment for chronic gouty arthritis? Right, so chronic gouty arthritis, we give uricosuric agents, or the other group of drugs will be the drugs which will decrease the uric acid synthesis. What is that uricosuric agent? That will be rasburicase, and the other drug will be probenecid. Okay, then the drugs which will decrease the uric acid synthesis are mainly xanthine oxidase inhibitors. And what are these xanthine oxidase inhibitors? That is allopurinol, and one more drug will be febuxostat. Okay, so that is about your gout or gouty arthritis. Okay, now yesterday in the cardiology we missed one important topic that has to be revised, that is infective endocarditis. Okay, so I'll quickly recap infective endocarditis in just 5 minutes, and with that the entire cardiology topics will be done. Right, so you take this infective endocarditis. What exactly is the definition of infective endocarditis? Where you have the development of friable vegetations over the valves, and thereby what will happen to the valves? There is valve injury. Right, friable vegetations over the valve, that will result in valve injury, and these vegetations, they are non-sterile vegetations. They are non-sterile vegetations. They contain infectious organism. Now tell me, which of the following have most friable vegetation? Which of the following has the most friable vegetation? So the most friable vegetation, you will have that in case of the infective endocarditis. Okay, then next you have in case of non-bacterial thrombotic endocarditis, which is nothing but merantic endocarditis. Then followed by that, you also have the friable vegetations in rheumatic endocarditis, and you also have that in SLE, that is lupus endocarditis. And this lupus endocarditis is nothing but your Liebman-Sachs endocarditis. Okay, now you should know what are the organisms that will be causing this bacterial endocarditis. Is most commonly caused by which organism? Is most commonly caused by, right, so please remember, it is most commonly caused by a highly virulent organism, that is Staphylococcus aureus. That will be the most common organism that will be responsible for your bacterial endocarditis. Okay, it is not your beta hemolytic streptococci, right? It is your Staphylococcus aureus. Please remember, this is very, very important question. Then you need to know about prosthetic valve endocarditis. So prosthetic valve endocarditis, we classify this into two types, that is early prosthetic valve endocarditis and delayed prosthetic valve endocarditis. So early prosthetic valve endocarditis is that which occurs within 60 days of insertion of the prosthetic valve. Delayed prosthetic valve endocarditis is that which occurs after 60 days of the prosthetic valve insertion. Now you should know what is the organism causing prosthetic valve endocarditis. So if you take the organism within 2 months, what would be the most common organism causing prosthetic valve endocarditis? Will be the most common organism will be coagulase negative staphylococcus, right, which is nothing but your Staphylococcus epidermidis. Whereas 2 to 12 months, even 2 to 12 months also, it is the same organism, that is your Staphylococcus epidermidis. Okay, whereas beyond 12 months, what is the most common organism causing prosthetic valve endocarditis will be is Streptococcus viridans, right, Streptococcus viridans. Now in case of infective endocarditis, you should know a very important syndrome that is called the Austrian syndrome. which is also called Osler's triad. So Austrian syndrome or Osler's triad is characterized by a triad. What is that? They will have pneumonia, they can have meningitis, right, and they will also have development of infective endocarditis. And what is the organism here? The organism is Streptococcus pneumoniae. So it is very easy to remember. One, brain involvement, meningitis; lung involvement, pneumonia; heart involvement, infective endocarditis. Now for the development of infective endocarditis, you should have an underlying cardiac lesion. Yes, any one of you? Which of the following cardiac lesion is at highest risk of occurrence of infective endocarditis? ASD, MVP without MR, valvular aortic regurgitation, MS. Okay, the question is the highest risk. The highest risk. Anyone? The highest risk, remember, the answer is valvular aortic regurgitation. Valvular aortic regurgitation. Okay, now you should know what are high risk, moderate risk and low risk lesion. So if you take the high risk lesions, the high risk lesions are, they include AS, AR, then MR. Then we have the congenital diseases like VSD, PDA, coarctation of aorta, right, coarctation of the aorta, and tetralogy of Fallot. And one more high risk lesion will be prosthetic valves. These are the high risk lesions for the development of infective endocarditis. What are the moderate risk lesions? Mainly they are stenotic lesions, MS, TS and PS. Then followed by that we have MVP with MR, then TR. These are the moderate risk lesions. Low risk lesions are ASD and MVP without MR. So how you will remember this? In all these lesions, across all these lesions, there is high pressure difference. Across all these lesions, when there is high pressure difference, there is high tendency of endothelial rupture causing infective endocarditis. Okay, now images are very important in infective endocarditis. Okay, so in patients with infective endocarditis, there can be development of the splinter hemorrhages, right? And over the palm and sole, there are two important images. So one is Osler's nodes. Where are these Osler's nodes? They are present over the pulp of the finger. And these Osler's nodes, they are very painful, very, very painful. Okay. Next is the Janeway lesions. So how will be these Janeway lesions? These Janeway lesions, they are non-tender. Right? These Janeway lesions are non-tender. Okay. Now, these infective endocarditis, they can also have digital infarcts. Why is that they will have this digital infarcts? That is because of embolization of the vegetation to the digital vessels. That is because of embolization of the vegetations to the digital vessels. And the another important lesion in case of infective endocarditis will be Roth spots. So this is a very important question. Roth spots, what are the other conditions where you will have these Roth spots? You will have this in diabetes mellitus. You will have this in patients with hypertension. You will have this in patients with severe anemia. You will also have this in patients with polycythemia. You will also have this in patients with the SLE. And you also have this in patients with polyarteritis nodosa. These are all the differential diagnoses where you will have the presence of the Roth spots. And what is the name of the criteria for infective endocarditis? The name of the criteria will be the Duke's criteria. But this particular name Duke is used in multiple places. The Duke staging useful for carcinoma rectum. Duke scoring for chronic stable angina. Right, for chronic stable angina. Now you take this Duke's criteria. So Duke's criteria, what is that? You have major criteria, then you have the minor criteria. So major criteria is that where you have the presence of large vegetations, and that can be made out on the 2D echo. The other important is the culture, more than or equal to 2 cultures should be positive. Then what is the minor criteria? Okay, see, I cannot post the Telegram channel link because that this particular channel, that is Unacademy YouTube channel, does not accept the links sharing in the description. That is what I have tried yesterday also, but I was unable to. So if anyone can do that, who are there in my Telegram channel, please share the Telegram channel link. I'll try once again. Okay, so I have sent you now. Just check whether you are able to join with that or not. Okay. Right, that's what you see, like it is not accepting. Okay, so I think the channel, I mean the link got deleted by itself. Right, now you take the minor criteria. So minor criteria, there are totally 5 minor criteria. First and foremost, now I have actually sent it in the description, but it is automatically deleted. Why? Because this particular channel does not accept the links in the description. That is what the log system they these people have put. So that is why I am unable to send the link. So you can just text me on my WhatsApp. I have shared my WhatsApp number, so I will send you the link there if you are unable to join on my Telegram. Okay, right. So you take the minor criteria. So minor criteria, right? Number one, fever. Fever should be more than or equal to 100.4 degree Fahrenheit. Okay, and then there should be an underlying predisposing cardiac lesion, right? And there should be vascular phenomenon. So what will be this vascular phenomenon? That vascular phenomenon will be Janeway lesions. Janeway lesions are vascular phenomenon, and even mycotic aneurysms and intracranial hemorrhages. And another important minor criteria will be the immunological phenomenon. So what will be this immunological phenomenon? Osler's nodes, Roth spots, and as well as glomerulonephritis. Then culture, that should be positive. But the culture that is positive, it should not meet the major criteria. According to major criteria, 2 cultures are positive. But according to minor criteria, even if 1 culture positive, we take that in the minor criteria. Okay, so that is about your major and as well as minor criteria. Then how do you treat these patients with infective endocarditis? We need to give antibiotics. So we give ceftriaxone as an empirical antibiotic. Then we give vancomycin. So this will be the antibiotics that you will be giving in these individuals. So vancomycin we give 1 gram, and your ceftriaxone we give 2 grams. Okay, so this will be empirical antibiotics, right? Then you should know what are the indications of surgical treatment in case of the infective endocarditis. Number one, failure of medical management. You need to do surgical treatment. And if there is presence of abscess within the myocardium, then also surgical treatment. Then if there is aortic valve endocarditis, if there is aortic valve endocarditis developing the heart block, if there is aortic valve endocarditis developing heart block, that is also indication for surgical treatment. And if there is prosthetic valve endocarditis, then also you need to do surgical management. And if there is large vegetation causing the risk of embolism, then also surgical management. And another condition is fungal endocarditis. So these are all the indications for surgical management in patients with the infective endocarditis. Next, last important thing in the infective endocarditis you should know is, see, American Heart Association guidelines recommending infective endocarditis prophylaxis before any procedure. So now see, this is a very important area for infective endocarditis. Which group of patients they require infective endocarditis prophylaxis before undergoing some oral procedure, like some dental procedure? So patients with prosthetic valve endocarditis, they have to take infective endocarditis prophylaxis. Then patients with past history of infective endocarditis, they also have to take infective endocarditis prophylaxis before undergoing dental procedure. Then if the patient is having unrepaired, right, unrepaired congenital heart diseases, and that too which type of congenital heart diseases? It is complex cyanotic congenital heart diseases like tetralogy of Fallot and all. they require infective endocarditis prophylaxis before undergoing dental procedure, right? And the other group of individual is the cardiac transplant recipients. Cardiac transplant recipients who develop valvulopathy, right? Who develop valvulopathy, they require the infective endocarditis prophylaxis before undergoing dental procedure. Now the point is, like, what is that antibiotic that you give for prophylaxis? Now if you are giving through oral route, then you have to give penicillin, the amoxicillin. And if the individual is allergic to penicillin, the other options are clindamycin or cefalexin or azithromycin or clarithromycin. Okay. Now, if you want to give the antibiotic through parenteral route, right, you need to give ampicillin, because some patients before the surgery they may be NPO, nil per oral. So in them you need to give parenteral route where you need to give ampicillin. And if the individual is allergic to penicillin, then the IV that you give is clindamycin or cefazolin should be given. Okay. So this completes your infective endocarditis, right? With this, I wind up the today's session. With this, I wind up today's session. So tomorrow, right? So tomorrow, the same time, I'll try to discuss pulmonology for 1 hour, CNS for 1 hour, and GAT for 1 hour. Okay, so with this, the entire all the topics will be finished in the medicine. Pulmonology, CNS, and GAT 1 hour. So with this, the entire quick recap of all the medicine topics will be done by tomorrow. And after that, I will discuss previous year questions, clinical based questions, image based questions. But all this I'll try to do before your FMGE exam. So by 18th, I'll wind up all the quick revision program related to general medicine on the YouTube live sessions. Okay, right. And I have said you previously also, right? In those individuals who are unable to find my my Telegram channel, you can text me on my WhatsApp. So I will send you the link immediately after the class, and the PDF I'll be sending you on on that particular Telegram channel. Okay, right. So with this, I wind up this session. Thank you very much. See you again tomorrow at 6 p.m.